So, sir, it's 3, 2, 1. Over to you, sir.
Mm, Good morning. Today again on second Sunday of this February month of 2025, FOGSI ICOG brings another edition of PG Clinic. This time we are having lot of important discussion, and at the outset I would like to express my sincere gratitude and thanks to FOGSI President Dr. Sunita Tendulwarkar, FOGSI ICOG Chairperson Dr. Parag Biniwala, Dr. Swarna Khadilkar, Secretary General, for giving us this opportunity to continue with PG Clinic. As you are aware, this PG Clinic is going on for last 3 years, and with all of your support and cooperation, we are successfully running this program. We have with us Dr. Sarita Bhale Rao, Secretary of ICOG, and I have with me my coordinator, Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, who are ably and strongly supporting in continuation of this program. Today, we are having fetal skull and maternal pelvis, various type of abnormal pelvis by Dr. Haresh Doshi, another eminent teacher from Ahmedabad Medical College. After that, we will be having case discussion on RH isomerization. Earlier, we have discussed about RH negative pregnancy, how to manage that. But today, we will be discussing on isoimmunized pregnancy. And we have students from AIMS, New Delhi, and Dr. Aparna Sharma, professor at AIMS, is the coordinator. She has helped us in preparing the case. And we have, again, eminent teacher, Dr. Deepika Deka, ex-professor and head of the unit from AIMS, Delhi. Then Dr. Sarita Bharelao is another faculty. Dr. A.G. Radhika is the senior consultant from UCMS. And Dr. Ipshita Mohapatra from AIMS Bhubaneswar. So we have faculty and students from different parts of the country having this discussion and have participated, and they have we are also obliged to them that they have consented to participate in this program. After that, in master the technique, as per the NMC guidelines, we have to have now competency based, skill based learning, where every student is given the chance to learn skill, and they should have the competency in her subject or his subject. So we are having this today, master the technique on LEAP, loop electrosurgical excision procedure. And we have Dr. Amita, principal and professor and head of the department of UCMS Medical College. And as we have started in this year, after that, we will be having a quiz for half an hour. And again, the quiz will be on RH isomerization. And Dr. Archana Kumari, chairperson of FOGSI quiz committee, along with her team, will conduct the quiz. And as per the response of last month, we feel that this is a very popular segment of the program, and many students are interested in participating in the quiz. So with all this, now I would like to again express my sincere thanks to FOGSI President Dr. Sunita Tendulwarkar, ICOG Chairperson Dr. Parag Biniwala, and my all eminent faculty and students, and all the participants, and all our PG students from across the country, for sparing your valuable time for this Sunday morning. And I now request our chairperson, Dr. Parag Biniwala, to say a few words.
Thank you, Dr. Ashok. Good morning. I bring greetings. It's indeed a pleasure to be talking to you again on episode 2 of Master ICOG PG Clinic for the year 2025. I'm looking forward to one very interesting session where we have eminent faculty like Dr. Harish Doshi, who's a very popular teacher from Gujarat. A special thank you to all the 4 examiners, Dr. Deepika Deka, Dr. Sarita Bhalera, who's the secretary of ICOG, Dr. A.G. Radhika and Dr. Ipsita Mohapatra. And thank you, Dr. Amita Suneja, who's going to talk about the procedure LEAP, which not many postgraduate students must have seen. Thank you to Dr. K. Aparna Sharma, professor from AIMS, New Delhi, and the 2 students, Arti and Shraddha. Best wishes to you. You're going to present interesting case today, and I'm sure this will be a good rehearsal for you when you appear for your MS exam in the future. And the additional element of PG clinics is the quiz. And like we decided last time, the winners will receive prize from ICOG in the form of books. We are soon to release a book on research methodology, which will be extremely useful for our postgraduate students. Dr. A.G. Radhika and myself, we edited this book, and this will be released officially during the ICOG conference on 1st and 2nd March in Pune. I also take this opportunity to invite all the students. They have ICOG conference where they can present their work and get rewarded. And of course, all in the audience who are eligible to become fellows and members of ICOG, you still have an opportunity to apply for fellowship for ICOG till the 15th of February, wherein if you will be awarded the fellowship during the ICOG conference in Pune. Thank you once again and happy.
Thank you, Dr. Parag sir, for giving us a word of encouragement. And now I request Dr. Hafizur Rahman to say a few words, and then we can start with our presentations.
Yeah. Yes, sir. Good morning, everyone. Respected our ICOG chairperson, Parag Benyala sir. And then we have Ashok sir and all other faculties and students and all the students who have joined from all over. Now, as we have gone, this is we are 4th year in this program. And I have got requests from many students, that is, we have been doing, that is normal mechanism, bridge and rest. So many students requested to the various abnormal types of pelvis, which I am sure this will give a very important insight for the students. And Professor Harish Doshi sir, who is professor and HOD at GCS Medical College, Ahmedabad, sir will deal with that. And then again, some students have again want to clear their concept on RS isomerization, and I'm sure this case presented by the AIMS students, that is AIMS New Delhi student, Dr. Arti Saini and Dr. Shraddha Agarwal. They will present an isomenized pregnancy and how it is managed. I hope this will be very much interesting for the students to clear their concept, and they are guided by Dr. Aparna Sharma, Professor AIMS Delhi. And we have faculty, those are expert in this field actually, and their inputs will be really helpful. So we have Professor Deepika Deka, Madam is ex-professor and head of the unit of maternal and fetal medicine. And then we have ICOG secretary and consultant at Saifi Hospital. Yes. So, and finally, as one procedure, Amita Suneja Madam will present the case. And especially, we have got the request and interest by many students for the quiz competition. The quiz will be conducted by Dr. Archana Kumari. So Madam is chairperson of FOGSI quiz committee. Then Dr. Rijesh Robi and Dr. Bhavna Tiwari. So they will be conducting the quiz. So without wasting any time, I'd like to would like to request for the first session, that is various type of abnormal pelvis and how the mechanism of labor is altered in those situations. That will be dealt by Professor Harish Doshi sir. So over to you, Harish Doshi sir. You can please.
Thank you, Dr. Hafizur. At the outset, I must thank FOGSI President, Dr. Sunita, ICOG Chairperson Dr. Parag, other office bearer Dr. Ashok Kumar, and Madam Sarita Balirao, and FOGSI Secretary, also other coordinator Dr. Ashish Kumar, for inviting me to deliver this topic of fetal skull and maternal pelvis, various types of abnormal pelvis and effect on the mechanism of labor. Frankly speaking, nowadays, what is happening, as we all know, the incidence of cesarean section is increasing like rocket speed, 30, 40, 50, 60%. But still, labor is going to stay. And as a postgraduate, not only for exam point of view, the student must learn the art of labor and all mechanism and theoretical aspect of labor, very useful in practice also. Now, before we start the different types of pelvis, let me tell you the very old classification. Am I seen there? Hello? Full screen? Hello?
Yes, sir.
I think my video is okay, fine. Fine. Though more than 90 years back, in 1933, Calvin and Molloy, two researchers from USA, they studied a couple of thousands of females who have delivered normally their pelvis radiologically. And then they classify into 4 types, which is not very useful, but still we take it for our purpose of study. And 50% will have they divide into 4 types depending upon the shape of pelvis as well as the other features of pelvis, but not the size. We are concerned with the size because actually it is a cephalopelvic relationship. But still, this is important for basic understanding. And that gynecoid pelvis makes a 50%, typically round shape of inlet and all roomy space because it is meant for the delivery. Second in incidence is anthropoid ape-like pelvis, which is anteroposteriorly oval pelvis. Gynecoid is round shape. Here, anteroposteriorly oval. Third is android pelvis, triangular pelvis. Sorry?
Sir, Doshi sir, can you move the camera a little bit far because it is not completely visible, the pelvis. Yeah, okay. Now it's better.
Thank you.
Sir, you can keep a little bit away from the camera also, that will be more visible.
What?
But now it is much better.
Okay.
Yeah, sir, away from the camera. So because becoming too close, so it is not coming in. Now, yeah, okay. Sir, perfect, sir.
Yes.
Yeah, now we can go.
Thank you. So the second one I told you, anthropoid, anteroposterior. This is symphysis pubis and this is sacral promontory. It is anteroposteriorly oval, that is anthropoid. Then there is triangular, wedge-shaped pelvis. There is android, 20% of cases. And when it is a transversely oval, it is platypeloid pelvis. Right. Originally, he made 4 types, but then it was not pure. This different types are not found. And so he made combination of the anterior segment of other shape and posterior segment of other category. And the combination of term denotes the true pelvis, that is gyne-android. But the first word determines or refers to the posterior segment of the pelvis. So gyne-android pelvis is having a gynecoid features of the posterior part of the pelvis and android features of the anterior part of pelvis. So theoretically, you can think of 4 different types: gynecoid, anthropoid, android, and platypeloid. But then you make 2 combination, 4 into 4, 16 types. But practically only 14 types. 2 types, as you can think of, not possible. Anthropoid with platypeloid, that type is not possible. Same, platypeloid with anthropoid. So only 14 types of mixed pelvi are there, but even intermediate varieties are also found. So this is a basic classification, and we will go into study of these 4 types and then some abnormal pelvis. So first is gynecoid pelvis. A normal size gynecoid pelvis will lead to normal mechanism of labor and normal delivery. All steps of mechanism taken in the past, ICOG PG sessions. Now, what I am referring today is even if it is gynecoid features, if it is slightly narrow, it is called generally contracted pelvis. Now, if it is borderline contraction at all level, features are gynecoid. What happens in the mechanism of labor, that everything is delayed and prolonged because it the space problem. Feet shape is gynecoid. Head baby size is normal. So when head goes down, then there is a problem of little decrease in space. So in a gynecoid contracted pelvis, generally contracted pelvis, they call it, if it is borderline. If it is severely generally contracted pelvis, no choice. You have to go for cesarean section. Here, you require either a good force of uterine contraction, power, or not or, along with that, molding also happens somewhat more, +2 type, and vaginal delivery may be possible. But remember, mechanism of labor is same, starting from engagement till the delivery by extension, restitution, and extra rotation. Okay. Now coming to the next common type of pelvis, that is anthropoid pelvis. Anthropoid pelvis is anteroposteriorly long. It is in 25% of pelvis, right? Human, it is anthropoid, human, ape-like, right? What happens here, the fetal head, right, is in occipito anterior position or occipito posterior, right? Because AP diameter is long. That fetal head position is either occipito anterior or occipito directly posterior, but it is in anteroposterior diameter. Okay, engagement occurs in anteroposterior diameter, like that space. What happens is engagement is easy because anteroposterior diameters and all that. But at mid cavity, because AP is longer, anteroposteriorly, transverse is less. So at mid cavity, where internal rotation has to occur, that may not occur, right, or delayed, or posterior rotation more common. Posterior rotation, that we have seen, you must have learned in occipito-posterior, anthropoid pelvis causing occipito-posterior, and then rotation may occur posteriorly. Still, if it is an average size baby, phase tube baby's delivery can happen that the root of the nose, this is baby, root of the, right, root of the nose here, that can come, right, at symphysis pubis. First the flexion occurs and then remaining if the head delivers. So that is, you know very well, phase 2 pubis delivery, root of the nose hinging against the symphysis pubis, and then first by flexion head delivers, remaining of the posterior head, and then the face delivers. So that is if it is phase 2 pubis delivery, and if it is happening with average size baby. If the good size pelvis, anthropoid can also cause occipitosacral arrest and further problems. So this is right? Anthropoid pelvis, second common variety. Now, android pelvis. See, remember two things. Gynecoid and anthropoid, good for vaginal delivery. Android and platypeloid, suboptimal for vaginal delivery. Can happen, rarely, because as such, Calvin and Molloy, when they studied, they took all patients who have delivered normally. In them, they also found 20% android. But android can give rise to more problem, occipito-posterior arrest, obstructed labor, everything. Now, anthropoid. So anthropoid is triangular or waist-shaped pelvis. The posterior space is more. What happens in anthropoid pelvis? The fetal position of a fetal head is occipito-transverse or oblique, right? The engagement occurs in a transverse, right, or oblique diameter of the pelvis. Either transverse or oblique diameter of the pelvis. Engagement may occur that way. Problem occurs is there is engagement is not there. There is a difficult engagement. Because of slight deflection, the engagement may be delayed. And engagement may occur in a comfortable way in anthropoid, but in android, engagement may be delayed. Some deflection is out there, and because the bulky occiput is there posteriorly. So engagement is delayed and problem occurs for internal rotation in the mid cavity. So engagement is delayed here, engagement, right? If it is a pelvis is triangular, the baby is right going in a transverse position or oblique posterior position, and then at the down in the cavity, the internal rotation either right gets arrested or long internal rotation like of occipitoposterior, right, and there is a problem. Due to poor rotation, there can be incomplete rotation. There can be, as we have learned in occipitoposterior, you can have deep transverse arrest or oblique persistent occipitoposterior position. And many times, if you are not accustomed to instrumental delivery or right manual rotation of the head in occipitoposterior, the cesarean section is the answer. So Android is suboptimal for delivery. The engagement occurs in a morely transverse and posterior position. The engagement is delayed, but internal rotation may occur, may not occur because of shape of the pelvis, altering the mechanism, or incomplete rotation leading to transverse arrest, oblique arrest, or occipitosacral arrest, right? If it is anthropoid with occipitosacral position, face to pubis delivered, as I show you, happens. But android, it is not found. So android means a problem. And it is a male type pelvis. Male pelvis is like triangular, andropelvis, not meant for vaginal delivery. So less space downwards, right? Okay. So last one is a platypeloid pelvis. Platypeloid pelvis. Now, platypeloid pelvis is a transversely oval. This is inlet. This is inlet. I will show you inlet. This transversely, when it becomes anthroposteriorly flattened, right? So that is platypeloid pelvis. Very rare, very rare. 5% of our pelvi only like that. The fetal position of the fetal head is naturally transverse because transverse space is right. Anteroposterior diameter will go in a transverse position of the fetal head. So that fetal head in a right transverse position, transverse. Okay, fetal head is in a transverse position. Now the engaging diameter, right, is a okay transverse diameter, engaging diameter, position occipitotransverse, engaging diameter transverse of the inlet of the pelvis. Engagement is delayed. Here also it is delayed because anteroposterior diameter is shortened. Anteroposterior diameter is shortened. So BPD cannot accommodate to that. So what happens? There are two things you have to think of in platypeloid pelvis. Either the head is shifted laterally where there is an bay of near the ala of sacrum, sacrocotyloid diameter, there is a space. And so what comes in a midline is bitemporal. And this bitemporal is a lesser diameter, bitemporal. Head goes not in the midline because BPD cannot go. So it goes this way, if you imagine. So bitemporal can come, but that lateral space is not much available. So what happens is the next thing which I'm mentioning is asynclitism happens. What is asynclitism? It is a parietal obliquity. The one parietal bone is lower than the second parietal bone. If it is anterior asynclitism, the anterior parietal bone is lower down, and if it is right like this, in the posterior asynclitism, the posterior parietal bone is lower down than the anterior parietal. Why this happens? Because once there is asynclitism, the diameter, anteroposterior diameter of the fetal head, right? This is the with asynclitism, the anterior parietal bone is going down. What is the AP diameter? Subparieto-supraparietal. Not BPD, subparieto-supraparietal, which is 8.75. 8.75. So if it is BPD, it is 9.4, you know, but with slight tilting of the head either towards sacrum or towards symphysis pubis. Anterior means towards sacrum, the head is tilted, anterior parietal bone is low down, which is good. It is happening in multipara anterior asynclitism. And when this happens, anterior asynclitism, the further progress can happen. Suprosubparietal, 8.75 centimeter. And once it goes down, it gets corrected, asynclitism, and further mechanism. If it is posterior asynclitism, again the good size that it common in primi gravida, Lidzman obliquity. Anterior is called Naegele's obliquity. Anterior is better, happens in multipara. primary, it is posterior, primary gravida is a posterior asyncretism, but then it cannot traverse the whole symphysis pubis anteriorly. Problem occurs in a right posterior asyncretism. But transverse platypelvoid pelvis, remember that the engagement is delayed, difficult because BPD cannot, because anteroposterior diameter of the pelvis is shortened. Anteroposterior diameter is shortened. So BPD cannot accommodate that. Either goes laterally, BPD goes laterally, or head tilts, and subparietal, supraparietal diameter 8.75 will negotiate, and then its syncretism lower down in the pelvis gets corrected. So this anterior rotation also may be delayed because the pelvis is transversely narrow. So anteriorly it may not allow the baby head to rotate, and what happens is baby descends in a transverse. At the outlet, some good space is available. The internal rotation occurs very low down in the pelvis. So in a platypelvoid, engagement is delayed. The descent also, and particularly internal rotation, is delayed. But at the outlet, once delivery, when the complete internal rotation happens, delivery is no problem, right? It does not get stuck at the outlet. Once it reaches the outlet, the good diameters, right, for baby head to rotate, and right. So that is a platypelvoid pelvis. So, or 4 different types of pelvis, little alteration in mechanism, but if the shape may be any, but size is good for average size baby, vaginal delivery is still possible with little alteration in the mechanism, like in a generally contracted pelvis. I repeat, gynecoid pelvis, small, slightly little small, the more and more force, more time, more molding, and delivery will occur. Engagement, right? Descent with flexion, internal rotation, right? Crowning, extension, restitution, and external rotation. Same mechanism normally, but anthropoid pelvis, again, I repeat, the AP diameter is longer, so it remains in an occiput anterior or occipitoposterior, right? The right descent occurs, and in right rotation may be a problem because transverse diameter less, AP diameter is not. So rotation may not occur. And if it is a good size pelvis, occipitoposterior position, phase 2 pubis delivery can occur. Phase 2 pubis delivery with hinging of the baby's root of the nose and at the subpubic arch. First the posterior head, then the anterior. Third one is android pelvis. Again, android pelvis, either transverse position or oblique position, the fetal head is there, right? And the engagement is delayed because of bulky occiput is there in a posterior part, as well as some deflection is there. So engagement is delayed, rotation is also incomplete, may lead to incomplete rotation and arrest, and more chances of operative delivery. Android pelvis. Platypelvoid pelvis, if good shape, head remains transverse, engages descent, rotation may not occur till outlet, and then only. Sorry, I also forgot to tell you that engagement has a problem because of BPD. Anteroposterior diameter is shortened, which I told you earlier, that either lateral going to the head on the lateral side anywhere, and then bitemporal will be there in a midline, and or subparieto supraparietal diameter with asynclitism will happen, and then it leads to engagement, further descent in a transverse, no internal rotation till outlet. At outlet, good space is available, and just before delivery, you can, if you see such delivery, you can witness at the crowning, after crowning or near crowning, the head rotates. So that is very clearly you can imagine. So these are the normal pelvi. When you think of contracted pelvis, you know the anatomical definition is any essential diameter of the pelvis, any at inlet cavity or outlet, shortened by 0.5 centimeter. Some authorities say 1 centimeter. It is contracted pelvis. If obstetrical definition, any of the essential diameter of true pelvis so much shortened, not by 0.5 or 1. So much shorter. So as to alter the normal mechanism of labor, then it should be called as a contractile pelvis. So it's the obstetric definition, right? Now, the pelvis, right, different types according to shape we have discussed. Only thing, some of the abnormal pelvis, many causes of contractile pelvis, many causes. Now, they are rarely found. The developmental causes, they are, say, one ella of sacrum is not developed, and this goes nearer, so transverse diameter decrease. Mostly you require cesarean section. This is called Nigel's, right, pelvis. Then the Robert's pelvis, right, Robert's pelvis. So Robert's pelvis, both ella, right, both ella are not developed. Both ella, only the sacral body is there, vertebrae. Ella is not there. So pelvis is fused, literally both sides. Pelvis is fused to sacrum, and naturally very narrow pelvis. It cannot happen. Then there is a developmental other problem is high assimilation type of pelvis. Fifth lumbar vertebrae is making the first sacral vertebrae. Sacrum is made up of 6 sacral vertebrae. So the whole length of pelvis cavity is more. It favors occipitoposterior, long journey, long descent, and problem. May again lead to, right, failure of progress and cesarean section. Another variety is good. It does not cause problem. That is not a contractile pelvis. Low assimilation type of pelvis. First sacral vertebrae is incorporated into lumbar vertebrae. So sacrum is now made up of only 4 sacral vertebrae. So less space, less depth of the pelvis. It can enter and come out. So low assimilation is not a problem for us. It is an abnormal pelvis, but it is not a problem pelvis. Right. The high assimilation, yes, occipitoposterior and arrest. The both Robert and Nigel's pelvis causing a problem. Then there is a nutritional deficiency. Again, this is not malnutrition, and particularly calcium and vitamin D. If it is in child, rachitic flat pelvis. Rachitic flat pelvis is happening in a childhood because of deficiency. The bones are weak. Bones are very weak. And so the gravity effect of the right body weight as well as the muscular action makes the pelvis changes. And what happens in rachitic pelvis, the sacrum is pushed anteriorly, the symphysis pubis. So anteroposterior diameter is sacral promontory is jetting forwards because of weight and because the weak bones, right? And then what happens is this rachitic pelvis is problem at inlet only. While in platypelloid pelvis, the problem of transversely, right, long pelvis is at all level. Anteroposterior diameter is shortened. If it is shortened only at inlet, it is referring the rachitic flat pelvis. Okay, so it is right. The pelvis become reniform shape. Both things comes here nearer, and this is a problem. Now, this same deficiency when occurs, right? In a older age, that is adult female, it leads to right problem of, you can say, osteomalacia, lack of calcium and vitamin D, right? Now, this can develop after in adult life. So even after 2 deliveries, this osteomalacia can develop. So don't think that because she had a normal 2 deliveries, 3rd delivery will be normal. Because of spondylolisthesis, subluxation of joints, as well as osteomalacia, pelvis may be now affected. And what the affection is, same is like you can rickets, you can think of, and there is promontory is pushed down, lateral walls are also pushed because of, right, bones are weak and weight-bearing adult is working. And so triradiate pelvis, you can make a triradiate pelvis, and the symphysis becomes big-like because of muscle pulling and weight affecting the bones. Big-like, right? That is, I'm sorry, this you can say, this is, right, symphysis pubis coming here, and this becomes big-like, symphysis pubis, big-like. Triradiate pelvis. As this is pushed by the femur head, acetabulum going inside, right? Okay, triradiate pelvis, transversely flat pelvis. These are all features of this, right? Okay, that rickets have all other body features, not pelvi. This is the same thing here happening. that triradiate pelvis, big like, and right. Okay. So this is osteomalacia. Again, vitamin D, calcium deficiency. Nowadays, with vitamin D supplementation, it is less found as compared to past, rickets as well as vitamin D. Now, the other nearby bones affecting the pelvis, say spines, say lower limbs, pelvic bone itself, see fracture of the pelvis, some bones broken, some surgery done, and then right hip joint fracture or hip joint dislocation or fracture of this hip bones. So that can lead to problem. Even tuberculosis can cause problem, right? It can produce tuberculosis of spine along with the pelvis. So kyphosis is also there. When there is a see, spine deformity higher up in the body will not have problem in the pelvis. Naturally, spine deformity due to any reason at lumbar region will affect the pelvis because lumbar is directly connected with the sacrum, lumbar vertebrae. So that will produce kyphoscoliosis will make, right? Kyphoscoliosis will make problem occurs in a usually Cox and rickets patient. Scoliosis involving lumbar region, acetabulum is pushed forwards, right, inwards, right, okay. And polio in one lower limb, right, weakness. Now polio, one word of caution. We have delivered many patients of polio vaginally. Polio equal to cesarean section is not there. You have to again assess the pelvis, right? With right compensatory space on the other side, there is a space for average size baby to deliver. There may be, not always, but you don't think of that the patient had polio. Now polio is also gone, and that is a very rare to find, zero polio. But think of that in our times, we have delivered many polio patients vaginally. But other deformities, severe kyphosis, severe scoliosis, spondylolisthesis, right? All bones jetting forward and occupying the space in the pelvis cannot have vaginal delivery. So cesarean section automatically becomes the answer in this patient. So lower, right? Okay, so this is a thing that, okay, I'm sorry. These are the normal pelvi forceps affecting the mechanism of labor. Then abnormal pelvi, contracted pelvis, either nutritional or infection, tuberculosis. Nutrition is rickets, osteomalacia. Infection is tuberculosis, malnutrition. And also the deformity of joint, lower limbs, as well as spine, bony injuries to the pelvis, fracture of pelvis, disease of pelvis can cause abnormal pelvis. So we have to keep this in mind. How can we make out this thing right? By lastly, in an other without any other etiology of contracted pelvis, clinical pelvimetry is the answer. I'm just going for that, right? The diagnosis of abnormal pelvis. How do you diagnose abnormal pelvis? Naturally, from the history, right? Past history of difficult labors, past history of diseases, past history of operation or pelvic surgeries, right? So any past history important, obstetric history, pelvic surgery history, pelvic disease history, and that will tell you. Then also the physical examination, stature, short stature, not always all short stature will have narrow pelvis, but slight incidences increase as compared to other normal height population, female. So that is there. And that is a dystrophia syndrome. Short, stocky female, right? Mostly leading to oxytopsia position and all that. So that short stature, gait of the patient, waddling gait or something, not waddling, but some deformity, limping and all that. You can see the patient walking in your OPD and think of that this patient will have pelvic problem. Also, right, the stigma, rickets, stigma, other places of the body, you can make out. Then in abdomen, what is to seen? Either there is a malpresentation because pelvis is problem contracted, or there is a pendulous abdomen because the head cannot, the baby cannot go down. Or if it is head, it is a high floating head, right? High floating head because it cannot enter. If it is still a vertex presentation, and you want to check that two tests, clinical tests, not me use much, but still Pinard's abdominal test, where you, right, patient is lying with, right, two finger with the head, right, I'm pushing the head down per abdomen, and right, I'm sorry, and with this, I'm measuring the overlapping or sympathetic pubis. It goes in, okay, it flushes borderline. If it overrides the sympathetic pubis, Pinard's, right. Same thing you can do by PB examination, and so Munro-Kerr Muller method, Muller-Kerr method. So abdomino-vaginal method, that is for diagnosing CPD. Two clinical methods, Ian-Roll method is also there with the fundal pressure, but this for diagnosing CPD. You think of some, right? Okay, so these are, after all this, history, examination, abdominal examination, head fitting test, you think that it is there. The final answer is clinical pelvimetry. So you must learn the art of clinical pelvimetry, right, at all level, inlet, cavity, outlet. Mainly 5 S are important. Sacral promontory, sacral curvature, sacrocytic notches, subpubic arch, right? So this S, remember. Otherwise, you have to see everything at all level. But clinical pelvimetry will tell you which type of pelvis is there, right? Whether it's a platypelvic pelvis, transverse is very good, but AP is less. Anteroposterior is good, and transverse is less. Anthropoid pelvis, funneling pelvis, triangular, that is android pelvis. So that clinical pelvimetry is the answer for you to differentiate the type of pelvis, and we are mainly concerned with CPD. Head is a very good pelvimeter. Head is a very good pelvimeter. If head engages, descends, and good progress of labor, it is there. And we are concerned with delivery. We study for all, why pelvis, and this thing we study to have the outcome, normal labor. And if it is a borderline, if it is a severe disproportion problem or severe deformity or severe abnormal pelvis, cesarean section, elective cesarean section. But one thing in past, our books may mention premature induction. No, it is not, right, evidence-based proof. Premature induction will lead to premature. So cervix may not be good. And again, cesarean section, premature baby will come, right? And even if vaginal delivery happens, the prematurity problem and pelvis might have some compressor effect of the baby's head. So premature induction was once favored, is not an answer for borderline contract pelvis or contract pelvis. Cesarean section or borderline, you can give trial of labors where you put all the variables of labor, power, passage, passenger on test and monitor the patient. If it is good progressing, right, and ending in vaginal delivery, you can help out that second stage, maybe cut shorter, maybe do instrumental outlet lift, forceps or vacuum, or vaginal delivery itself. So that is trial of labor for borderline cases and cesarean section for more than borderline abnormal pelvis. So I think I have covered, because right, time is short, already 12:16. So if you have any query, I can answer. But otherwise, nowadays we think that normal labor is a retrospective diagnosis. Patient enters in labor, spontaneous or induced, progresses, dilatation, descent, and delivery. That is a retrospective thing, right? If it does not happen, we consider failure of progress, whatever reason. If it is correctable, we will correct it, but we go for we have decreased our threshold for cesarean section, and we are going for cesarean section for any trivial indication, which is not good, but it is the need of the time. 30% is very well nowadays accepted rate of cesarean section. But vaginal delivery gives you much satisfaction and pleasure to everybody, patient, you, and relatives. Okay, thank you. Hello.
Thank you so much, Haresh Joshi sir.
Yes.
Thank you so much for your excellent presentation. I am sure this will help the students very much. If any question is there, the students or anyone can put in the chat box, and sir, I would like to answer it maybe in the later on. Now, Doshi sir, I would like to request you to stay back for this case presentation as well.
Hafizur, which case is there? Hafizur, I am already committed.
Okay, sir. If you are not free, that's okay. Okay, sir. If you are engaged, this is RH examination. So
yeah,
for
very
the
good
next
topic.
case,
Very good topic. But
yeah,
I
this
think
is
I checked the dry run also. I saw they prepared nicely, and examiners
yes,
are
sir.
fantastic.
Yeah, sir. Thank you, sir.
Thank
So
you.
we
Thank
have
you
the
so much.
students. Thank you so much, sir. Thank you so much for your excellent inputs, and I'm sure this will be recorded in the ICOG as well as in the YouTube record. The student can access later on also. Thank you so much, sir.
Thank you.
So now we'll move on to the second session, that is the case discussion on this. The case is on RH examination. The students are from All India Institute of Medical Sciences, New Delhi, and they are guided by Dr. Aparna Sharma, Professor AIIMS Delhi. So Dr. Aarti Saini and Dr. Shraddha Agarwal, they will be presenting the case. And we have faculties. Dr. Ashish Mukhopadhyay sir is a little busy, but he will be there somewhere. Then we have Professor Deepika Dekha, madam. Madam is ex-professor and head of the unit, SIF Maternal Fetal Medicine, AIIMS Delhi. Then we have our ICOG secretary, Madam Sarita Bhalerao. Madam is consultant at Saipi Hospital, Mumbai. Then we have Dr. A.G. Radhika. Madam is senior consultant, UCMS and GTB Hospital, New Delhi. And we have also with us Dr. Ipshita Mahapatra, Associate Professor, AIIMS Bhubaneswar. So I'd like to ask the students to please share your screen and introduce yourself and start presenting the case. And I would like to request the faculties to take over, please. Madam Deepika ma'am, Sarita madam, Dr. Radhika, and Dr. Ipshita. Please take.
Dr. Hafiz,
Yes, ma'am.
thank you very much for inviting, but I think there's a lot of background knowledge, background noise. Yeah. So, Dr. Aparna, yeah.
Yeah, hello everyone and good evening. And we are really happy to be here today. So we have with us Dr. Aarti and Dr. Shraddha, who will be discussing a case of RH isoimmunization who's currently pregnant and being followed up in AIIMS. And we do have with us Dr. Dekha ma'am, our teacher, and very esteemed panelist who would be taking this case forward. So thank you very much.
Good afternoon, everyone. I am Dr. Shraddha and
myself, Dr. Aarti.
And we will be presenting a case on RH isoimmunized pregnancy. Our patient is a 29-year-old female resident of Daryaganj, a homemaker and graduate, belonging to lower middle socioeconomic class, having a blood group of A negative and husband is O positive. She had her last periods on 15th of May. She had her last periods on 15th of May 2024, but has history of irregular cycles and is not sure of dates. Her POG is 25 plus 5 weeks by first trimester ultrasound. She is now gravida for para 3 with 2 living issues. She has been booked at AIIMS from 14 weeks POG and has been followed with ultrasound Dopplers in view of RH isoimmunized pregnancy. She was previously admitted twice for IUT and has now been admitted for a third IUT in view of raised MCPSV. This was an unplanned pregnancy. A UPT was done at 5 months amenorrhea, which was positive, and ultrasound was done, which showed an intrauterine pregnancy corresponding to 13 weeks POG. She had her first visit at AIIMS at 14 weeks and was booked, started on folic acid. Blood investigations and ultrasounds were done, which were told to be normal. On reviewing her previous OBS history, a plan was made for IVIG administration. She received a first dose of IVIG at 14 plus 5 weeks POG. 70 grams was given in 2 divided doses over 2 days. And the second dose of IVIG was given after 1 week at 15 plus 5 weeks POG. In the second trimester, she was immunized, started on iron and calcium tablets, and anomaly scan was done, which was normal. Ultrasound follow-up was done weekly, starting at 16 weeks, and she had a total 9 antenatal visits. She was admitted, she had a first IUT at 24 plus 6 weeks POG, and second at 25 plus 3 weeks POG, which was on 3rd of February. her previous OBS history. Her first pregnancy was in 2018. She was booked at Loknayak Hospital from 5th month POG. Her antenatal period was uneventful. She remembers receiving anti-D at 7 months POG. She was induced in view of term pregnancy and underwent emergency cesarean section in view of non-descent of head. She delivered a female baby of 3.2 kg. The blood group of the baby is not known. The baby did not receive phototherapy and no history of NICU stay. And she remembers the patient received anti-D postnatally and was discharged on day 5. Her second pregnancy was in 2020. She was following up at Sanjeevan Hospital. ICT was done and she received anti-D at 7 months POG. She was diagnosed as GDM and IHCP and was managed for the same. At 36 weeks, she developed decreased fetal movements and went to the hospital and was told to have an IUD. Emergency cesarean was done in view of placenta previa and she delivered a male baby, which according to the patient was hydropic. It was a fresh IUD and birth weight and blood group of the baby is not known. She has no history of PPH or blood transfusion and does not remember receiving anti-D postnatally, and she was discharged on day 3. Her third pregnancy was in 2022. She was following up at Apollo Hospital, where at 26 weeks POG, she was told to have ICT positive and ultrasound suggestive of fetal hydrops. She received her first IUT at 26 plus 5 weeks POG, where her pre-IUT hematocrit was 9%. She was then followed with weekly ultrasounds, and then at 29 weeks POG, she was referred to AIMS in view of fetal hydrops. She received 3 IUTs at AIMS at 3 to 5 days interval, last at 30 plus 4 weeks POG. At 34 plus 3 weeks, when she was planned for her 5th IUT, due to severe fetal anemia with technically difficult IUT being a posterior placenta, emergency cesarean was done and she delivered a female baby of 2.5 kg with an Apgar score of 7 and 9. The baby had respiratory distress, probably due to prematurity, and was intubated and shifted to NICU. The baby received partial exchange transfusion at 10 hours of life in view of cord hematocrit 33% and thereafter received phototherapy for 48 hours. The blood group of the baby is O positive. The baby was uneventfully then discharged on day 24 and was under regular follow-up. Received 1 PRBC transfusion at 3 months of life. Now is currently 2.5 years old with no neurodevelopmental impairment. Her menstrual history: she had her last periods on 15th of May 2024. Her previous cycles were irregular with a cycle length of 2 to 5 months. Her past history was otherwise not significant and has no history of blood transfusion. Her mother is diabetic on oral drugs and blood group of the mother is Rh positive. She consumes non-veg diet and has normal bowel and bladder habits. She consumes 2300 calories per day as against her required 1900 calories and has a protein deficit of 25 grams. She belongs to lower middle socioeconomic class by modified Kupaswamy scale.
So coming to the examination, patient was examined after taking verbal consent. Patient was conscious, cooperative, and well oriented to time, place, and person. The general physical examination was unremarkable. However, her BMI was 27.8 kg per meter square, making a class 2 obesity with pre-pregnancy weight of 75 kgs and height of 164 centimeter. Her blood pressure was 110 by 70 millimeters of mercury, measured in right arm in sitting position. Her pulse rate was 84 beats per minute, regular, good volume, and measured in right radial artery. Respiratory rate was 16 per minute. Her central nervous system, cardiovascular, and respiratory system examination was unremarkable. On per abdomen examination, on inspection, umbilicus was inverted, central, and all quadrants were moving equal with respiration. The abdomen was longitudinally ovoid, and the linear nigra was seen. A 10 centimeter transverse scar present in the suprapubic region, which was healed with primary intention, and all hernial sites were intact. On palpation, abdomen was soft, there was no local rise of temperature, uterus was 26 week size, external palatability was present with no scar tenderness. On auscultation, uterine supple sound was heard. So coming to the case summary, our patient, 29-year-old female, she is gravida 4, para 3 with 2 live issues at 25 plus 5 week period of gestation by first trimester scan. She is booked at AIMS, immunized with RH isoimmunized pregnancy with history of IVIG, 2 doses received in current pregnancy with 2 IUTs. With history of fetal hydrops in the previous pregnancy with previous 3 LSCs with no other comorbidities. So coming to the management she received in this pregnancy at AIIMS, she received intravenous immunoglobulin given 70 grams over 2 days, that is 1 gram per kg. So she received 35 gram each day at 14 plus 5-week period of gestation, and the repeat dose was given at 15 plus 5-week period of gestation. Followed by MCPSV monitoring was done from 16 weeks onwards. So this is her MCPSV monitoring chart. She was monitored with MCPSV. The MCPSV found to be raised at 24 plus 4-week period of gestation. That is a value of 1.78 MOM, which is greater than 1.5. So she was planned for intrauterine transfusion at 24 plus 6 weeks period of gestation. With pre-IUT hematocrit of 12.1, she received 20 ml of O negative PRBCs via placental cord insertion site, and post-IUT was 27.4. So she was planned for second IUT at 25 plus 3 weeks period of gestation. At this time, she received 30 ml with the post-IUT hematocrit of 14.1. She was followed with MCPSV monitoring, and currently the MCPSV is raised, so she is planned for her third IUT. So her ANC investigations, ICT was not repeated in this pregnancy as her previous pregnancy was already affected by eye drops as the cause is RH isoimmunized pregnancy. Antibody screening was done, found to have NTD as well as NTC antibodies. Her blood investigations were within normal limits, aneuploidy screening was normal, and level 2 suggestive of no gross congenital anomalies. So assessment of how can we assess for the fetal anemia. So there are non-invasive as well as invasive tests. Non-invasive. Yes, ma'am.
We can probably stop here, ma'am, and have some questions.
Think so?
I think that's a good idea.
Yeah. So,
Yeah. So
if anybody among the faculty wants to ask any questions,
I do, Dr.
yeah,
Deepika.
Dr.
Good
Radhika,
morning.
please go
Yeah,
ahead.
yeah.
Good morning.
So this is not associated with this RH business at all. My one basic question is, this lady already had, obviously there is a problem in her obstetric performance even earlier, and RH isoimmunization was identified. Was she at all advised any contraceptive? Why is she going on producing children? She's got previous 3 cesareans, and now she's had a difficult antenatal and postnatal period even in the earlier pregnancies. So I'm just curious to know, why is it that we are not able to tell this lady? So I would like to ask Shraddha and Aarti.
Yes,
So
ma'am.
even before we delve into the intricacies of this case, obviously it is complicated and we need to go into the depth of what is happening and all that, isn't it? So if this lady were to come to you, so she was 14 plus 5, I think, at the time when she came to AIIMS. So, do you think, this was an avoidable problem? Because it is not only just producing children, it is a lot of stress to the treating team as well as to the couple. So, what is your take on this matter? If you had seen her in the earlier pregnancy, and let us rewind the clock and let us think that you were the person who was dealing with her in the last pregnancy.
Ma'am, the patient had taken contraception after her second cesarean as well as after third cesarean. She had a copperty inserted, but due to AUB, she had it removed after 5 to 6 months. And ma'am, when she came to us in this pregnancy also, she was counseled about, she was aware of her previous pregnancy. She had a long hospital stay. And in this pregnancy also, ma'am, she was counseled about the possible need for multiple admissions and a longer hospital stay. And she, ma'am, is a well educated and well aware patient, and she and the husband, they opted to continue pregnancy, ma'am.
It would be really nice if you had highlighted that in your presentation. The contraceptive history was extremely important. And I would also wonder, this lady received a copperty, she had AUB removal after 5 months. Probably that was also the right time to consider ligation. She could have been offered some other method of contraceptive, and it could be both temporary, it could be large in terms of injectables, or it could be also ligation, isn't it? So, so there are two aspects in this lady. So one is that she has had a bad obstetric history, and in terms of her RH sensitization. Number two, this lady has a BMI of 27 plus. So there are two aspects to this discussion. So I just wanted to start with that premise to understand why this lady is going on conceiving. So so that part of the history, if it had been there, we would have appreciated it.
Yes, ma'am.
So over to you, Dr. Deepika. Would you like
Yeah.
to start on the, yeah.
Any other thing? Dr. Sarita, would you like to say something? Good morning.
Yeah, good morning. And yes, my question is that can you just tell us where this patient got iso-immunized in your opinion? And what are the blood groups of the other children? You must be knowing.
Ma'am, she didn't remember her first baby's blood group. And in second pregnancy, she remembers her antenatal NTD, that is at 28 weeks, it was given, but her postnatal NTD, she is not aware about that.
So where do you think she got iso-immunized, and do you think it could have been prevented?
Yes, ma'am. As she has received 2 doses of both doses of NTD in her first pregnancy, but there is still 0.2% risk of isoimmunization. And in second pregnancy, the postnatal NTD was she's not aware, so this might be also the cause.
So you think that she didn't get the postnatal NTD, or maybe do you think that the feto-maternal leak was more?
Yes,
Is
ma'am.
that possible?
Yes,
Yes,
ma'am.
ma'am.
Yeah. And because of a complicated pregnancy. So what are the cases in which feto-maternal leak is more, and you need to consider higher NTD?
Yes, ma'am. If the patient is having recurrent episodes of antepartum hemorrhage in the previous pregnancy, there is any history of abruption, or in previous pregnancy, if there is any history of postpartum hemorrhage or any history of blood transfusion. So these are certain conditions in which we need to
Say,
give.
Dr. Aarti, nowadays nobody would give blood transfusion without doing. So in this case, what you think was the problem? She had a cesarean. Is cesarean the hardest factor?
Yes, ma'am.
Yes, ma'am.
Cesarean increases the feto-maternal hemorrhage. And also she had IUD, and probably within 72 hours of detection of IUD, she might not have received NTD, which
No,
is
but
No,
where
what
were
did
the
you say?
earlier, the
IUD.
earlier,
The
yeah,
IUD
but
has occurred because of hydrops.
Yes,
So we
ma'am.
are talking about feto-maternal hemorrhage. What could have caused increased feto-maternal hemorrhage, and she got immunized? So you think that the amount of NTD given was not adequate? In what conditions amount of feto-maternal amount of NTD is not adequate?
Ma'am, if in the previous pregnancy, if she is having recurrent episodes of antepartum hemorrhage, so we have to repeat
Yes.
NTD at 6 weeks interval, and we have to
So
check.
one is that. Anything else?
Ma'am, she didn't give any history of postpartum hemorrhage, but
So
no, but
antepartum
Aarti,
hemorrhage?
I'm just curious to, sorry, Dr. Deepika, I just wanted
No,
one
please go ahead.
clarification. Yeah. So these cesareans, as far as the chart that I saw, which you had presented, Aarti and Shraddha, so this was, where did she deliver? How come she doesn't have the blood groups available, and she receives even partial exchange transfusion and all that? Yet you say that her blood group is not known. That's kind of, and even if she did not know, was it a good idea to even consider, getting those papers of the past? Did you go into the discharge slip and all that?
she did not have discharge paper of her first pregnancy. She had discharge paper of her third pregnancy, in which the baby blood group is O positive. It was mentioned.
Okay. How about this fresh IUD? Because these are good hospitals. LNJP Hospital, Sanjeevan, Apollo. So,
Yes.
And especially given the fact that both the couple is educated and all that. So it's kind of counterintuitive to not for them not being able to give you this kind of history. So I think it's an important point which Dr. Sarita also asked you. What is the point at which, what is the reason why this sort of a thing is happening, no? Repeated. So carry on, please. Carry on with the discussion.
I think maybe we can go ahead then.
Yeah.
Dr.
So
Deepika, would you like to?
one question, madam. Deepika, madam, can I ask?
Yeah, Ipshita, yes.
So, Aarti, you told that there are increased chances of feto-maternal hemorrhage, and then the anti-D dosage has to be increased. So, how do we calculate that? The dose of anti-D?
Yes, ma'am. Ma'am, the 300 microgram which we routinely using NTD dose, so it is for 30 ml of 30 ml of the fetal whole blood, and for the 15 ml of fetal RBCs.
Okay, so if it is increased, how do we then increase the dose?
Ma'am, for 1 ml it is increased by 125 microgram.
Yeah, her question is, how do you know that the woman has had more feto-maternal hemorrhage than
What
what can
test
be
is being done?
counteracted?
Yes. Yes.
There are two tests which are available. One is flow cytometry and another is clear or bed case test. The clear KB's test, in which it is an acid elution test, in which the fetal RBCs contain HbF. So it is resistant to the acid, but the maternal RBCs contain hemoglobin A. So it is not resistant. So the fetal RBCs will be appear as pink cells after hematoxylin stain. However, the maternal RBCs will appear as gauze cells. So by that we can know that the fetal maternal hemorrhage, the amount of
Yes,
RBCs.
right.
Yes.
I can tell you all once we had a case of APH and abruptio, and we had to give her 3 injections of anti-D. So 1 injection may sometimes not be adequate. Okay. And when we do cesarean, we have this, habit of removing the placenta immediately. No. So what are the precautions you take in an RH negative woman to see that the amount of fetal-maternal hemorrhage, which is maximum in the 3rd stage of labor, is minimal? What precautions you will take?
Ma'am, we will follow a controlled contraction and avoid manual removal of placenta where possible. We have to use oxytocin preferred over ergometrin in cases of atonicity. And ma'am, during 2nd stage of labor, 1st and 2nd stage, fundal pressure should be avoided to decrease.
And
That
Yeah.
should
Any
be the
other
case for
things?
all deliveries.
Any other thing?
Shraddha?
Yes. Anything else?
Ma'am,
Fundal
splitting of
pressure is a
membrane
big no
also
for any
avoided.
delivery.
Ma'am,
Fundal pressure is a big no for any vaginal delivery.
Yes. What
Shraddha
else?
and
What
Aarti.
other precautions you will take? What about the cord clamping in cases of RH?
Ma'am,
Negative women.
RH negative and RH isoimmunized is not an indication for
early cord
cord clamping, ma'am. Delayed cord
No, do you clamp the cord at all on the maternal side?
And we will prefer that the fetal cord should be long, so that if the baby will require transfusion later on, so to get umbilical vein catheterization, it is easy.
That is one thing. I'm saying for prevention, what you should do is you should let the cord hang down. The cord should not, the cord blood should not touch the episiotomy site, or when you're doing a cesarean, blood should not spill into the abdomen because they can be absorbed. So you should pack the abdomen. I'm talking about cesarean. And if it is a vaginal delivery, let the cord hang. Don't clamp the clamp on the maternal side. What is the blood coming out from the maternal end of the cord? Is it fetal blood or maternal blood?
So,
It's fetal blood.
Yes,
It's
ma'am.
fetal blood. It is not that the patient is having PPH if you don't clamp. It's all the fetal blood which is carrying RH positive blood, which will all be drained out, because if you clamp the cord and the uterus retracts, then the blood goes back into the mother's circulation. So don't clamp the cord on the maternal side. Let it hang with gravity and into a petri dish. Okay? And so some precautions should be done. Another thing is we have the habit of clamping the cord, putting over the abdomen and start stitching the episiotomy. So that also should not be done. It should be allowed, and the placenta should separate on its own. No active management of 3rd stage of labor.
Yes, ma'am.
So another cause of where there is increased fetal-maternal hemorrhage is MRP, if you have to do for some other reason. Then also there would be, and then twins. Because you have 2 placentas, it could be, okay? But we always give do we increase the amount of anti-D given in a normal twin pregnancy delivery? In an ICT negative twin delivery, what is the dose of anti-D?
Ma'am, the dose
is same. 300 micrograms.
Is same. But what could be a risk factor? Because you have 2 fetuses.
The amount of fetal-maternal hemorrhage can be more.
Yeah. Normally, how much is the fetal-maternal hemorrhage at delivery? Normally. No PPH.
Ma'am, it is 10 to 15
10
ml.
to 15
Not
ml.
more than 15 ml.
It's usually not more than 10 to 15 ml. So 30 ml, if it covers 1 injection, it covers more than enough, no?
Yes, ma'am.
Okay? Yeah. Dr. Ipshita, any more questions? I don't see any questions in the chat box. Where are we supposed to see questions from the audience?
Yeah. I think in the
It
chat
would-
box only, we can request the audience to put any questions, but otherwise we can go ahead and we can
Yeah,
discuss.
we can
I have a
proceed.
question to ask Shraddha and Aarti. Now, this lady in the past pregnancy, September 2022, her ICT was 1 in 256. So what is was she came at 14 plus 5? What was the dilution titer at that time?
Ma'am, in this pregnancy, she was referred here. In third pregnancy, she was referred at AIMS at 29 weeks. Previously, she
Okay.
was following at Apollo Hospital, but her previous ICT records were not available, ma'am.
No, you said
What?
that it was 1 in 256.
Ma'am,
That was in the
when she
last
presented
pregnancy.
to
Yeah, but after that, they have not repeated.
What is meant by a critical titer?
Yes, ma'am. If the critical titer is that is 1:16. If the titer is more than 1:16, then we have to follow the patient with MCPSV monitoring.
No, what is the definition of a critical titer? Why is it 1 in 16?
That is at that after beyond that level, the risk of fetal anemia increases beyond that antibody level.
Yeah.
There is a higher chance of hemolytic disease, isn't it? So now if it is 1 in 256, say if you had done it in this pregnancy and you found it was probably more than 1 in 256, what could you have considered early pregnancy?
Ma'am, increased titers are generally associated with worse fetal anemia and also in
We
RH.
agree. We agree on that, isn't it? Higher chance of fetal affliction. So what is the possibility today? Is there a role of plasmapheresis,
Yes,
maternal plasmapheresis?
Yes, ma'am. This patient received IVIG. Other options that are available is plasmapheresis or corticosteroids can be given, or under research is immunomodulatory drugs which can be given. The primary.
So let's talk of the established ones before we go into the research ones. So do you think she was we could have considered, it's a point under consideration. Plasmapheresis has a role.
Yeah, yes, ma'am.
Why
Yes,
we
no?
don't use it anymore?
So
We see a lot of patients with very severe eye drops, 5-6 eye drops coming. Huh? Why we don't do plasmapheresis anymore?
We don't.
How
So
much blood?
essentially,
How
if you
much
look at
plasma
it,
you need?
Shraddha
How
and
much
Aarti, I would
plasma
just
you need? Read up plasmapheresis. You need a lot of plasma. Okay. And what is the role of IVIG? You yourself have said that you have used IVIG. So how does IVIG instead help?
How is it
What is
better
the
than
mechanism of
plasmapheresis?
action?
Ma'am, IVIG will cover the FC receptors as well as it will inhibit the B
FC
cells.
receptors of?
Ma'am, FC receptors of B cells, ma'am.
Of the placenta.
Yeah, exactly.
Okay, and
So
prevents
important.
the antibodies from getting transferred from the mother to the baby. What else it does?
Ma'am, the secondary immune response that has developed in the mother, by giving we are giving immunoglobulins, so the immune system of the mother is and the immunoglobulin production in the mother is reduced.
It is said theoretically that it can do that. Can you also give IVIG directly to the fetus?
Yes, ma'am, it is seen that if we can also give IVIG to the feet. No, acha, ma'am, in the neonatal period, it is.
No, we are talking about fetus. Dr. Aparna can answer that because that was her thesis.
So basically, the idea is that if you give directly IVIG along with the blood, so it has been seen that it may decrease the requirement for blood transfusion. So along with blood, so you are giving 70 gram of IVIG to the mother, but the fetal weight is only 1 kg. So that way you will only require to give 1 gram of IVIG. So volume also becomes less, and along with the blood, you can give IVIG. With ma'am, we had some experience of, giving IVIG, and it had decreased the requirement for blood transfusion. But the point here is that, you are giving at the time of IUT. So you're waiting for the requirement of IUT. But if you give IVIG to the mother, you would probably delay the requirement for IUT. So those are the things which make it different. And if it is possible, we can give IVIG so that at least 2 to 3 weeks, you can postpone the requirement for intrauterine transfusion.
Yeah. Okay, Dr. Aarti Shraddha. how do you normally manage a case of Rh negative pregnancy?
Yes, ma'am. Ma'am,
Yeah.
If a patient of Rh negative, a woman who is Rh negative conceives, and at a first visit to the hospital, we have to get in blood group of the partner should be done, and ICT can also be done to look for other antibodies. And if the husband is Rh negative, we can manage it as a normal pregnancy.
ICT should be always done.
Yes, ma'am.
It's not that it should also be done. Okay? You must always do it.
Yes.
In fact,
And
it is now.
at what time do we do the ICT? At what weeks of gestation? After what time can we do that?
Ma'am, at first antenatal visit, we should do her
So
ICT.
can we do it at 5 weeks?
Yes, ma'am.
Is it? So I think it should be done at 8 weeks.
And after 7 weeks onwards.
Yes, 7 weeks onwards. Because why?
Because the fetal production of antigen in the fetus starts developing after
Yes,
7.
around 35 weeks, 35 days of gestation.
No, that is the Rh group that forms, okay? The antigen, the reticuloendothelial system of the fetus is mature only at 16 to 18 weeks.
That is why.
See, initially it is the Rh blood group that is formed, okay? So now that will go over to the mother's side. And then after that, the mother will start developing the will develop the antibodies. Okay, you remember the mechanism of action. You have to tell like that.
Yes, ma'am.
Ma'am, can I add a point here? What Dr. Ipshita is saying about when to do the ICT, and I think it's very important to understand that, see, when we are doing an ICT at baseline, so we say you do ICT at booking because this is determining the previous isoimmunized status of the pregnant woman. So even if you do it 5 weeks or 6 weeks, it doesn't matter because that's just like the baseline. But when you do the second ICT at 28 weeks, it is to see whether this lady has become isoimmunized at pregnancy. So the recommendation is that you do the ICT at booking and then you do an ICT at 28 weeks. And if it is negative, then you give an anti-D. But what you're saying is also extremely important because the antigen starts expressing at 7 weeks. And that is why the previous finding, which told us that you don't have to give an anti-D if it was a spontaneous complete abortion before 6 weeks. And that's the logic because it happens after 7 weeks. So I just wanted to, put in this point here.
Now, I would even go a little further that you can even do pre-pregnancy in any patient who's Rh negative. You can do pre-pregnancy if she comes to you. Nowadays, patients are coming.
Yes.
Because you never know when she's had an abortion or, she's hiding something. Okay, she could be immunized.
Yes,
Yeah.
So my question is to Dr. Aarti now, is it important to know the fetal blood group and is there any way of knowing it?
Yes, ma'am. We can know the fetal blood group by doing the fetal blood sampling also. And as well as
you won't be doing a fetal blood sampling routinely.
Any other?
No, ma'am.
Any
And
other?
there is a role of cell-free fetal DNA testing also, which can be done after 16 weeks period of gestation. And if the
Can it be
fetal
done earlier? Is there a place of doing the cell-free DNA earlier? Fetal DNA?
it can be done after 12 weeks onwards also.
Even earlier?
Why is it important? Can you tell us that?
Yes, ma'am. If we already know that the fetal blood group is negative, then there is no need of giving NTD dose. And so we can avoid the expenditure also, ma'am.
Yeah,
As well-
I was talking more in terms of an isoimmunized pregnancy. Then it perhaps will tell you the severity of affection.
In this patient, would you suppose if you had the chance and she came to you before she was referred, so would you like to do an NIPT? Is there any use for RH?
In an isoimmunized pregnancy, no, you mean?
In this patient.
Yes,
She's coming in her 4th pregnancy and she came to you supposing at 11 weeks. Is there any use of doing the blood group by NIPT?
Yes, ma'am. If the blood group of the fetus in an isoimmunized pregnancy, if the fetal blood group is Rh negative or positive, we can see if the baby requires monitoring for fetal anemia. If the baby...
Is there any chance that this baby, present baby, is negative, I mean, forget about the history after, the IUT and all that. Let's say she came to you at 10 weeks, 11 weeks. Is there any chance that the baby could be Rh negative?
Yes, ma'am.
Yes, ma'am.
The father's genotype testing can be offered.
Absolutely.
If
Yeah.
it is heterozygous, if the father is homozygous, then the baby fetus has to be positive, and cell-free fetal DNA might not be offered. But if the partner is heterozygous for RHD antigen, then cell-free fetal DNA testing can be done, and accordingly monitoring can be planned.
Yeah, so it depends upon the heterozygosity of the father.
Yes, ma'am.
There is a 50% chance that the baby could be negative.
Yes, ma'am.
Okay, right. So, anybody else wants to ask any more questions? Otherwise, they can
Yes,
go
I
on
do.
with their.
Yes, I do. So,
Yeah.
so while we are discussing the Rh negative aspects of managing this pregnancy, have you also focused on her BMI 27? What is her blood sugars, and what
Her
about rest
blood
of the
sugar,
things?
fasting, and postprandial value was done, which is within normal limits, ma'am.
Okay, so how much have we? What is your thought on managing this pregnancy, which is the starting point itself was on the higher side, the maternal weight?
Ma'am, she has the calorie requirement, since she belongs to class 2 obesity, the calorie requirement is decreased by 500 kilocalories per
So
time.
that's okay, Shraddha and Aarti. You tell us how much would you want her weight gain to be, and do you want a calorie restricted diet? You want her to lose weight? What is it like?
Ma'am, we expect the weight gain to be around 5 to 7 kgs, ma'am.
Over the 9 months?
Yes, ma'am.
I
You
think
should-
we also have some questions in the chat box, Dr. Deepika, before we.
I don't see. Okay, yeah. Yes, answer the question. How do you manage a diet in an obese woman? We are getting more and more cases nowadays, na?
Yes, ma'am.
Yeah.
Can you
She's
just
also.
briefly, just in 2 lines, just tell us what is the calorie requirement? You said 500 calories lesser. What did you say, Shraddha?
Ma'am, depending ma'am, on the level of activity the patient is in a sedentary
No,
female.
this lady, just tell us what you must have done it, no? You must have
Yes, ma'am.
got a dietary. Just tell us what you did. That's all.
Her calorie requirement as per her BMI was coming to be 2400 calories per day, and considering her BMI is in the obese range, we subtracted 500, and it is thus 1900 calories
How
required.
do you translate that into practice? What did you tell the lady?
Ma'am, we took a dietary history by 24-hour recall method, and for every meal that she takes, we calculated the total calories, and then she had a protein deficit, so we asked her to take more of protein-rich diet and calorie restriction in terms of avoiding rice and taking high fiber diet. मतलब brown bread वगैरह.
Okay, fine.
There's a question in the chat box about what is the dose of antenatal IgG? IVIG, I think it is. Yeah.
It is given
Dose.
1 gram per kg body weight, and we give over it is given in 2 divided doses over 2 days. So like this patient has a weight of 70 kg, so 35 gram was given on one day, and second day remaining dose was given.
And ma'am has to be repeated weekly. 16 weeks.
Weekly, because the half-life is. Yeah, there are different doses given in different by different authors. They also give 400 milligram per kg per day. So that becomes very, very expensive. So, we had devised our own doses. But in the baby, as we said, we can give it very easily, because if the baby is hardly like 600 grams or 1 gram, it becomes cheaper. Dr. Nikhil Kamarthi has asked, the reason for not clamping the cord is to prevent the backflow and mixing up of maternal and fetal blood query. Anybody wants to talk about it? I think the reason for not clamping the cord on the maternal side, what is the reason? It's in the chat box. Okay, let me answer this. I think it is to me. And that we don't clamp it because you know that in the third stage, basically the uterus retracts. the uterus retracts, and so when it is retracting, and if your cord is clamped, then the blood which is inside the cord and in the placenta will have no place to go. It will be pushed back into the mother's circulation through the open sinuses, and so that blood is Rh positive. So if you want to decrease the amount of Rh positive blood going to the maternal circulation, you need it to be drained out. And there's no better way than to not clamp it and let the blood in the placenta and the cord come out into the kidney tray. I think people are nowadays collecting cord blood, and you all know that there is about 150 ml of cord blood, which is in the fetoplacental unit. And that blood is Rh positive. So that is why. Dr. Sarita Bhalerao is asking you, when will you deliver this case? How long you plan to give her IUTs?
Ma'am, in case of...
In this case, we are discussing this case. Today she is 29 weeks and?
25 plus
25 plus 5.
25, yeah. So how long you want to go? Long way to go? What do you plan?
Ma'am, we'll plan her, we'll continue her, we'll plan her last IUT around 34 to 35 weeks. And after that, we will continue doing her MCPC monitoring as well as calculate her expected hematocrit. And we can plan
deliver at
37 weeks or earlier if there are neonatal concerns.
Yeah, we are nowadays going up to
37,
38 weeks also. If you're giving the last transfusion at 34, 35 weeks, which we started, then you can deliver her at term because there is no risk factor. The hemoglobin, there's no anemia.
Yes, ma'am.
So earlier, I'm talking about the early 90s, we were delivering them at 34 weeks. No, because we were not very confident about IUTs. So, but then over the years, the prognosis improved, and the prognosis is as good as 95, 96%, 98% Aparna. So,
yes, ma'am.
The risk of transfusion is much less. So we do the last one at 34, 35 weeks. You can easily go for 3 weeks after that and then deliver because the blood is mostly now negative. Rh negative blood in the fetus. Monica is asking, in the case of a ruptured ectopic pregnancy in a Rh negative woman with husband positive, do we need to calculate the dose of anti-D or give 50 microgram only? Ectopic pregnancy, do you need to give anti-D how much?
Yes, ma'am, at less than 12 weeks POG. For ruptured ectopic, we can 50 micrograms is usually sufficient.
Yeah.
Yes, ma'am.
Dr. Prasanna is asking, what are the other varieties of isoimmunizations? Other types?
Isoimmunization can be because of other antigens also, like antigen C, E, and other antigen like Cal antigen.
Cal, Duffy, Kid.
Duffy antigen, yes, ma'am.
No, so many other we can have. So
Yes.
how will you diagnose them?
Ma'am, when doing ICT, if any of these antibodies is positive, it will ICT will be positive, and then we can screen which antibody is positive.
Yeah. So if you find that the ICT is positive, but she's Rh negative, positive, she is Rh positive, isn't it?
Yes.
Mother is Rh positive. She has a bad history, like resembling immunization, but ICG is positive. Then you will have to do the other blood groups. And I think Aparna recently had a very interesting Japan.
Yes, ma'am. So basically, like for this question, I think it's important that there are 51 antigens, but there are some which are very high frequency antigens for which the isoimmunization is uncommon because everybody has those. But if there are an isoimmunization to the lesser common antigens like C and E, those are the situation. And we had one with the Rh17 antigen. So Rhd is the Rh1, and there could be many of them. But yes, we recently had for Rh17, which was 1 in 30,000. So I think that's something which is very rare.
Yeah. So how does the management differ?
No, ma'am. The pathophysiology is same. There is isoimmunization leading to fetal anemia. So monitoring and management is the same, except that the blood which is being transfused has to be screened and matched with the maternal serum.
And also,
Yeah, the
ma'am,
blood group has to be known, है ना? It has to be.
and
And
increasingly,
is there any point doing ICT again after it's reached the critical titer?
No, ma'am, there is no point to repeat the titer. We will monitor the patient with MCPSV, ma'am.
Yes. Okay, there's a question here which says how to manage twin pregnancy. I think these are questions which will come for the management. So you complete your presentation first.
Mm.
Okay, Dr. Radhika?
Yes, please. I just wanted a confirmation on this. Is KEL antigen isoimmunization worse than the DRH factor in isoimmunization? Is it in any way worse than the other one?
ma'am, KEL is okay.
Yes, ma'am.
Why?
Ma'am, in the CAL isoimmunization, even if the titers are low, there can be severe anemia.
Why?
Because does not cause hemolysis. Instead, it causes bone marrow suppression at the level of.
Exactly. So that it can be more ominous than the
Yes.
the DRH
I mean,
factor.
this even if the bilirubin in the fetal matlab, will
Absolutely.
be.
Yeah. I think you carry on with the presentation because the other questions are to do with management.
Yes, ma'am.
I'll briefly have to log out and then log in about 3 minutes time.
Okay.
Yeah. Thank you.
So there are methods of the assessment of fetal anemia, non-invasive as well as invasive methods. In non-invasive, there is MCPSV monitoring and to look for the signs of high drops. Invasive testing, which included amniotic fluid sampling, which is of historical significance, in which we used to see the bilirubin levels, and fetal blood sampling. So why we have taken the MCPSV? MCPSV is taken because of its anatomy. So whenever we are measuring it, there is a less degree of angle of insinuation. Mostly we like to have 0 degree of insinuation because of ease to access as well as reproducibility. There is less inter as well as intra-observant difference. And MCPSV at a value of more than 1.5 mOM, it has a sensitivity of 95 to 100% with a false positivity rate of 12% and a specificity of 85%. So how do we measure MCA-PSV? So we will take the axial view of the fetal skull and at the level of sphenoid ball and thalami. So we will take the Doppler caliper at the origin of the middle cerebral artery from the internal carotid artery with a minimal angle of insinuation that is at 0 degree and it should be less than 30 degree of angle of insinuation. So the Doppler waveform will be created and we have to take 3 maximum values of the waveform. And as per the MCA-PSV value, we will take the MOM according to the Maris et al. Chart. So if the MCA-PSV is less than 1.5 mOM, we will monitor the patient for 4 to 14 days. And if the MCA-PSV value is more than 1.5 mOM, we will consider the patient for chondrosynthesis as well as the intrauterine transfusion. However, if the period of gestation is more than 35 weeks period of gestation, if the MCPSV trend is within normal limits, we will induce the labor at 37 to 38 week period of gestation. However, if the MCPSV trend is increasing, we will consider planned the induction of labor. So what are the limitations of MCA-PSV? If the angle of insinuation, for example, is more than 30 degrees, it will underestimate the MCA-PSV. If the distal MCA-PSV that is far from the ultrasound probe is taken, it will also underestimate. And if we are measuring MCA-PSV after 35 weeks period of gestation, the specificity of MCA-PSV also decreases. So there are certain features which are also suggestive of fetal anemia, such as signs of high drops. In first image, we can see the ascites, and in second, placentomegaly. So if the placenta is more than 4 centimeter in second trimester, and
you can use your pointer.
And if the placenta is more than 4 centimeter in the second trimester and more than 6 centimeter in the third trimester, it indicates that placentomegaly is there. So this figure is suggestive of cardiomegaly. So how we know that the cardiomegaly is there? If the cardiac circumference is more than 50% of the thoracic circumference, it is suggestive of cardiomegaly. And this is another picture suggestive of polyhydramnios. It occurs because of the hyperdynamic circulation because of anemia in the fetus. So, another sign that is scalp edema, if the subcutaneous edema is more than 5 mm, so this we will measure, then it is suggestive of scalp edema. Another features of hydrops are there, such as hepatomegaly, splenomegaly, because of extramedullary hematopoiesis can be seen, and pericardial effusion can also be there.
Regarding intrauterine transfusions, depending on the period of gestation at which IUT is being done and the period of viability according to each institute, the patient has to be, if the patient has crossed the period of viability, patient has to be kept prepared for emergency cesarean if required, DEXA coverage should be considered, and neonatology team should be informed and kept in the loop. This is the patient information sheet in our department, in our center, which shows, along with the consent form, it mentions regarding the pre-op preparations that the patient can consider with the IUT, possible IUT complications, which is around 2% per procedure and around 5% per pregnancy complication at our institute. The prerequisites for blood to be given for IUT, it should be a O negative packed RBC, cross-matched to the maternal serum such that the transfused unit should be antigen negative for the antibodies identified in the mother. It should not be preferably more than 72 hours old and screened and negative for infections such as HIV, hepatitis B, C, and CMV. It should be leukodepleted to avoid CMV infection and irradiated to avoid graft versus host reaction, and is packed to a hematocrit of 75 to 80%. How do we calculate the volume of blood to be transfused? It can be calculated. One method is using the Mandelbrot formula. So we have to multiply the desired increase in hematocrit to the fetoplacental volume. The fetoplacental volume can be calculated as the fetal weight multiplied by 0.14. The final hematocrit is usually taken to be 40 to 50%, and the initial is the expected hematocrit of the fetus, and the divided by the hematocrit of the transfused unit, which is usually around 75 to 80%. For example, if the baby weighs 1 kg, the fetoplacental volume will be 0.14 multiplied by 1000 grams, which is 140 ml. And the required increase in hematocrit, considering the target to be 40 to 50%, and suppose the expected hematocrit is 20%, we require a 30% increase in hematocrit. And hematocrit of the transfused blood, if it is 80%, the volume comes to be 52.5 ml. Another method is by using the transfusion coefficient, where as per the required increase in hematocrit, the transfusion coefficient is selected and multiplied with the estimated fetal weight, and that gives the volume to be transfused. IUT can be done at the placenta loop, at the free loop, or intrahepatic, and each site has its own advantages and disadvantages. The placental cord insertion is technically easier but is associated with risk of fetal bradycardia. The free loop IUT can lead to fetal bradycardia and difficulty in penetration. And intrahepatic, although has fewer chances of bradycardia, is problematic to the fetus. We have some videos. This video shows IUT being done at the placental cord insertion. It depends whether the placenta is anterior or posterior. Posterior placenta is usually technically more difficult. This shows that we use a 20 gauge spinal needle which is being punctured through the placenta and into the placental cord insertion. A pre-IUT chordocentesis, before transfusing the blood, we take some 1 ml of blood to be sent for the expected hematocrit of the baby, and then the required calculated volume of blood is transfused. This video shows the intrahepatic, where the needle is inserted into the intrahepatic portion of umbilical vein and the volume is transfused. This is more traumatic to the fetus. And this is IUT being done into a free loop of cord. This is again same. This video shows the IUT procedure. A 20 gauge spinal needle is used, and these are the needles for taking the these are the syringes for taking samples, and vecuronium is loaded. Now, before giving IUT, we have to give some kind of local anesthetic to the baby to reduce fetal movements, and it can be either vecuronium or atracurium. The blood is then loaded from the blood bag, preloaded according to the volume to be transfused, is loaded into syringes and kept. The patient is then prepared and under asepsis and under ultrasound guidance. vecuronium is injected, which can be given either intramuscular or into the cord, and can be given either into the intramuscularly into the thigh or into the deltoid muscle. This is vecuronium being given into the gluteal muscle. The anterior placenta.
I think, Dr. Gupta, you can proceed with the questions.
Can you skip this part?
Yes, ma'am. In general, if we keep a final target hematocrit of 40 to 50%, however, in severely anemic fetuses at 18 to 24 weeks of gestation, we keep a post-transfusion hematocrit target of 35% or a fourfold increase from the pre-transfusion value, not more than that, to avoid sudden cardiac overload on the fetus. A second IUT can then be performed within 48 hours, and third procedure is scheduled in 7 to 10 days. Monitoring after IUT is MCA-PSV becomes less reliable because the fetal blood has now been replaced with adult RBCs, which are smaller and less rigid, and they alter the flow in the middle cerebral artery. And if MCA is being used, 1.69 is a better cutoff. And the rate of fall of hemoglobin is 0.4 gram per deciliter per day, and decreases with subsequent IUTs, and the hematocrit falls by 1% per day and reduces to 0.7 after first IUT.
What are the complications of this procedure?
Of IUT, ma'am? It can be associated with...
It's an answer. You don't have to go to the slide.
No, ma'am. Yes, ma'am. It can be associated with pre-labor premature rupture of membrane. It can, and infection can be there. Patient can go in preterm labor, and there is a risk of emergency cesarean section if the fetal viability is achieved.
And fetal bradycardia.
Fetal complications such as fetal bradycardia.
You can stop your slide share.
Yes,
I think you finished, no?
Yes, ma'am.
Yeah. So you have to say immediate complication. No, there can be fetal bradycardia.
Yes, ma'am.
That's the biggest thing. And there, of course, tachycardia resolves. So if there is bradycardia, what do you do?
Ma'am, we'll position the mother in the left lateral position. We will also start 1 unit RL, and we'll we will do the continuous.
Do you give anything like atropine or something to the mother? You can give atropine to the mother, put her, and then see how severe the bradycardia is.
Yes, ma'am.
No? Yeah. Okay, so we hope that you're going to have a very good outcome for this baby. And in the end, please don't forget to ligate her this time, as Dr. Radhika was saying. This is going to be her 4th cesarean.
Yes, ma'am.
Yeah. So is the number of cesareans also important? Why wasn't she ligated in the previous cesarean? 3rd cesarean? Do you normally ligate a woman in the 3rd cesarean?
And we offer ligation to patients who are eligible, and we offer ligation. This patient must also have been offered ligation, but
Yeah. So, but we do have cesarean so many, isn't it? How many have you heard of maximum or in the literature?
In our institute, we have seen after 3 cesarean.
3, 4, there are even the literature, even 9. What would be the risk in this patient because of the cesareans?
There can be risk of placenta previa, as already the patient had one placenta previa was there. So after 3, there's a risk of 60% risk of placenta previa. 40%.
So where is the placenta in this case?
Fundo posterior is there this time.
So in this case, it is not going to be a risk. So what are the other risk factors?
Ma'am, intra-op complications are expected to be higher because of previous 3 surgeries. And
why should it be high? Placenta is far away.
The risk of placenta accreta spectrum also, ma'am.
No, the placenta is far away. No, it's not in the lower segment.
What are the other complications that can happen?
Maybe adhesion she's talking about.
What adhesions can happen?
Okay.
She has history of 3 surgeries. So
when you are going to do her cesarean and it's an emergency cesarean, क्या problem हो सकता है?
Ma'am, bowel and...
this is what she's saying, no adhesions.
Yes, ma'am. bladder.
The
Can she
bladder
rupture?
Yeah,
Can the uterus rupture? This is going to be the 4th cesarean. She's already had 3 cesareans.
Yes,
Yes,
ma'am.
ma'am.
There is higher risk of scar dehiscence and rupture. And
What is one complication we are seeing nowadays after cesareans? The scar becomes thin out and sometimes ectopic pregnancy occurs.
see.
See, this patient
That
has
is the
a
biggest
lot of high risk factors. Na? One
Yes,
of
ma'am.
them is the cesareans. You have
Yes.
to manage that also. Have you heard of isthmosis?
Yes,
Yes, ma'am.
ma'am. Same.
What is it?
Ma'am, it is a defect in the
Defect
endometrium at the site of cesarean scar, which leads to collection of blood during menses,
Menstruation.
and it can lead to intermenstrual bleeding. It can also lead to infertility and
Yeah, and if she becomes pregnant, then
increased chance of adherent placenta.
increased chance of
Adherent placenta at the site.
is cesarean scar pregnancy an ectopic pregnancy?
ectopic pregnancy, and then the scar is very thinned out. We have monitored so many cases where you have to keep on monitoring them, no? Yeah. So this patient now, what is the future plan now? What you're going to do after this? You do the transfusion. We have talked about the complications that can happen during any intrauterine transfusion. There can be bradycardia, tachycardia, anything can happen. She can later on have PPROM, preterm labor, an infection. Immediate is the bradycardia and the tachycardia. And then how will you further manage her?
Ma'am, we'll monitor the patient. Weekly MCPSV monitoring will be done, and we will plan her last IUT between 34 to 35 week period of gestation.
No. Right now, after the transfusion, you will do the post-transfusion hematocrit.
Yes, ma'am.
So how will that help you to plan the next transfusion?
Yes, ma'am. We will calculate the rate of fall from the previous post-IUT hematocrit to the current pre-IUT hematocrit. And according to that, we will also monitor if whenever the patient having hematocrit of less than 30, we'll again plan for her intrauterine transfusion. And we'll also monitor the patient with the MCPSV monitoring, which is less reliable.
So she will probably need another, how many
intra-
transfusions?
Maybe
At least 3-4 transfusions she will need.
Yes, ma'am.
And then you will deliver her
Mhm.
by cesarean.
Elective cesarean section.
And you should motivate her for ligation from
Yes,
now
ma'am.
on itself.
Yes, ma'am, we have cancelled that.
Yes. Okay.
I just want to know from you, Shraddha and Aarti, but you said MCV is less sensitive. But can you explain to us why does
Dr. Radhika, I can't hear you properly.
Actually, now I'm inside. I'm going to the airport. So, is it better?
Yeah, we can hear you. Yes.
Okay. So, what is the rationale? Why does the MCV PSV increase with increasing anemia?
Actually, we can't hear you. I don't know. Can you hear?
I'll type it in the chat box.
Yeah, what ma'am is asking is, why does MCA PSV increase with anemia? What is the concept of increasing MCA PSV?
Okay.
With fetal anemia, there is decreased blood viscosity, and blood flow velocity is increased not just in MCA but throughout the blood, throughout all the vessels. But since MCA is easier to measure and has a blood flow which is parallel to the transducer probe, it is preferably measured for monitoring.
It increases because of the viscosity, also the speed. Okay, the blood flow increases, and then there is vasodilatation. When you put the probe, you know it's all red and blue. No?
Yes.
Yeah. So, anybody else has any more questions? I think they are going to manage the patient very well. They are also going to ligate her, Dr. Radhika. Okay, then we'll look at the questions here. How to manage twin pregnancy with different RH status in isoimmunization? Twins.
Yes, ma'am.
Different RH.
But the babies are having different RH blood groups. Hypothetically, how will you manage?
We'll monitor both the fetuses, ma'am, with the MCPSV monitoring, and if any of the fetus will be having MCPSV of more than 1.5 MOM, the blood will be planned for intrauterine transfusion, and the blood will be cross matched according to the type of antibodies the baby is having. The mother is having.
Yeah, RH, it's RH. So, Dr. Amrita Rai, I hope this answers the question that they are going to be monitored just like singletons. And whichever baby has a problem, that baby will be managed by transfusion. During pregnancy, what is the main problem? Dr. Aarti, Shraddha, what is the main problem that you have to manage? Anemia.
Oh, yes, ma'am.
The main problem is fetal anemia.
Yes, ma'am.
After birth, now let's talk about after birth. What are the problems that you have to manage?
Ma'am,
Broadly.
after birth, the baby is at higher risk of anemia, both early and late, jaundice, and can develop heart failure and features of
No, that will be subsequent to anemia.
Yes,
So
ma'am.
it's just two things, anemia and jaundice. So how is the baby managed after birth if there is in this such cases?
Ma'am, immediately after birth, a sample is taken from the cord and which is sent for blood group, DCT, and bilirubin and retic count.
If you send this baby's blood group for blood group, will it be correct?
Ma'am, after so many IUTs, the baby's blood group immediately after birth might come to be O negative, which we are transfusing. But
yeah. But otherwise, in RH negative women, you should always send.
Yes,
yeah.
ma'am.
And then you will monitor by?
Monitor by serum bilirubin levels.
Yes, clinically and by serum bilirubin levels. Right.
I think we need to conclude. And I'd just like to say it's been a fantastic case presentation and superb discussion. Any closing remarks, Dr. Deepika? Anything?
I think they have presented very well and they have managed the baby also very well. And of course, what I would like to tell all the students here is that the main thing is prophylaxis so that you prevent a mother getting immunized. So you must know the blood group of every woman who is coming to you at the first booking. We should do it. And also the ICT should be done at the first time that you meet an RH negative woman. The husband's blood group is positive. And we do not have really the facility for doing the heterozygosity. And the rule of thumb is take it for granted that the baby is RH positive and give the anti-D. We can nowadays do the NIPT to know what is the blood group of the baby, but it is quite expensive still. So even if you do the NIPT, we are not very sure that it is 100% sensitive, though the laboratories, they claim it to be, but we should monitor the babies. The best way to monitor is by doing ultrasound, as you said, by middle cerebral artery peak systolic velocity, and by other parameters of anemia. So the main problem we have to see is whether the baby is becoming anemic. Yes, carry on the pregnancy if necessary by doing transfusions when the hematocrit is less than 30 by repeated transfusions. So such patients should always be referred to centers which have a very good, team that does regular intrauterine transfusions. And after that, delivery should be aimed more towards term, not like earlier it used to be 32, 34 weeks. And after the delivery, the baby has to be managed in a very special neonatal ICU where there is facility for doing exchange transfusion and other treatment so that the baby does not succumb. We have had many patients where babies are delivered, but they die in the neonatal period. These babies can also have anemia up to 6 months, up to as long as the maternal antibodies are there. So they can have anemia later on. So the mother should be taught to diagnose jaundice and anemia. If the baby is pale, if the baby is looking yellow, they should be brought to the nursery, to the neonatal clinic to be shown. Yes, and of course, the baby has to be managed in such a way. And that's it. Dr. Aparna, I request you to give your concluding remarks.
Thank you very much, ma'am. And I think you've rightly summarized the management of the whole situation. And I would just add to say here that heterozygosity, so the use of NIPT has to be tailored properly. There's no point in doing NIPT in an RH negative non-isoimmunized women because the prevention might be less expensive. But there is a role of doing NIPT in RH isoimmunized women because that would decrease the anxiety and the number of ultrasounds that they would be requiring. And I think increasingly we might be moving towards doing NIPT even in our center. Thank you.
Dr. Radhika, Dr. Amita, nice to see you.
Yeah.
Concluding remarks? Yeah. Yeah, Dr. Sarita, we are done.
Yeah, thank you. Thank you so much. And I think it's been a wonderful session and really a great learning experience. Thank you on behalf of ICOG. I'd now like to request our next speaker, Dr. Amita Suneja. She's going to speak to us on loop electrosurgical excision procedure. She's professor and head of department at GTB Hospital, Delhi. Madam, are you ready with your presentation? Is
You're
Dr.
muted.
Amita?
You're muted,
You're
ma'am.
muted. And thank you, Dr. Aarti, Shraddha. Very well done.
Thank you so
Yes, excellent, excellent presentation.
So good afternoon, everybody. Nice to see you all.
Thank you, ma'am.
Yeah.
So
Would you like to share your?
Yeah, I'm sharing my slides. So can you see my slides?
Yes, ma'am. Your slide is perfectly visible to us. Just try to change the slide so we can check moving or not.
Okay. Yeah.
Yes, perfect, ma'am.
So tell me when to start. Can I start?
Yes, ma'am. You can start the session.
Yeah. So very good afternoon. At the outset, I thank the organizers, ICOG and Dr. Sarita to invite me for the topic which is very dear to my heart. And it is a video presentation. Basically, you have to master the technique. So I will tell you all the do's and don'ts and how to do it. So topic given to me is the LEAP. It stands for Loop Electrosurgical Excision Procedure. Now, loop, another word given to it is LLETZ. That is large loop excision of transformation zone. Now, this word is used by RCOG and this is used by the Americans. Basically, it uses electrosurgical, it's electrical energy. It is a surgical procedure. It is excisional procedure. So, and why, which term is better? That I would say I like this term LLETZ because LEAP, you can take a small biopsy with LEAP. It doesn't tell us that we are doing LEAP for CIN. So when we are doing it for CIN, we remove whole of the transformation zone. So it is a better term. Why large loop? With small loop, you can take a biopsy. For LEAP, for LLETZ, we use large loop. So the procedure is called LLETZ, or you commonly it is also known as LEAP. Nothing is wrong. More appropriate is LLETZ. So indications of doing LEAP procedure, it is the high-grade cell, high-grade lesion that is which consists of CIN 2 or 3. Now, this is an excisional method. So, LEAP is done for all cases of CIN 3. But in CIN 2 now the the guidelines are changing. That is considered as a mixed bag. Few cases of CIN 2 you can observe. You need not treat them, and if you want to treat them, you can give ablative therapy. But if CIN 2 is P16 positive, it is considered equal to CIN 3 and we have to give treatment. And in these are high grade seal, better to give excisional treatment until unless patient is nulliparous or she is adolescent. Another indication of doing LEAP is when we are really there's a discrepancy between the cytology, colposcopy, and punch biopsy, then it's better to excise and see what is the true histopathology. And principles of CIN treatment are that these patients are young. They're 10 years younger than the average age of invasive cancer. So we have to give them fertility sparing treatment, and LEAP is a fertility sparing treatment. Hysterectomy is over treatment for CIN. Never do hysterectomy just for CIN3. Okay, so LEAP is fertility sparing treatment, and as I mentioned, if there is a lesion, it is always a focal lesion, but we do not excise only the lesion. We excise the whole transformation zone, because transformation zone is the area which is at unrest, and this whole area is exposed to the HPV virus, where atypical metaplasia is going on. If you treat only the lesion, then the lesion will reappear in the other area of transformation zone. So treat the transformation zone in toto. And if we reach up to the depth of 7 millimeter, it is good enough to treat the CIN, because the gland crypts, they do not go beyond 7 millimeter, and there is no see, when we do it, then this whole transformation zone has to be treated, and this local lesion, though it is very evident, but we will excise the whole transformation zone. And in CIN, what we do, we reach up to 7 millimeter. There's no invasion of the basal membrane. So in LEAP, if you take a depth of 1 centimeter, you be on the safer side. It cures the CIN. And there are many methods of treating local ablation excision. So LLETZ or LEAP, if we do it with needles, straight wire, we call it as needle excision of transformation zone, or straight wire excision of transformation zone. Everything is same. Now I will not touch upon the LEAP cone, because cone can also be taken with the LEAP. So that's why I told you this is a better term. I'll limit myself to LLETZ, excision of transformation zone. Now, types of excision will depend on the types of transformation zone. You all know there are 3 types of transformation zone. Type 1, when both the new scamocolumnar junction and the scamo junction, the TZ lies out on the ectocervix, and we can see both the borders. Type 2 TZ is when the new scamocolumnar junction is inside the endocervical canal, but it is within the 1 centimeter and we can visualize it. It's called T2 TZ. When type 3 TZ here, when the upper margin goes into the canal and we cannot visualize it, it is called type 3 TZ, and this type of excision will be called type 3 excision. That means coniation. Type 2 excision, for that, can be done by LEAP loop, and we do top hat excision. I'll explain it later. For type 1 excision is ideal case for LEAP. Now see the type 1 excision. Now this whole of the transformation zone is on the ectocervix, and we select a loop size which can appropriate for the transformation zone, and in one pass we take out, do the loop. And so this is type 1 excision. I'll show you the video. Type 2 excision is that some part is in the endocervical canal. And also it has been seen that Indian cervices, they are multiparous females, cervices are hypertrophied. In one go, we cannot take the whole of the transformation zone. So you divide this leap, take it in parts. First part should be from the center, so that the whole of the columnar junction is taken. Then you can take multiple passes, anterior lip, posterior lip, or the lateral lips, and then preserve the pieces and send it for histopathology. Type 3 excision will be that it is inside the canal, which we can see or we cannot see. You first take out the ectocervix part, and involving the scamocolumnar junction. Then you change the loop. It is most of the time it is smaller and the squared loop, and remove the part of the endocervix that will form as a hat. So it is top hat excision or type 3 excision. So instrumentation is very important. It is an electrosurgical procedure, and we use diathermy machine or the LEAP machine. Now, LEAP machine will have 2 things in special. It is programmed. Like this machine which we are using, if we press 9 number, automatically the current settings will be of LEAP. And LEAP uses the blend current, and settings mostly are 70 current and 30 coagulation. But sometimes it doesn't work. We can increase the cutting to 80 and 20 coagulation. So coagulation for hemostasis, cutting is for removing the specimen. And there is also one button for the smoke evacuation. Now, smoke evacuation is very important because when you take the loop in the cervix, the lot of smoke accumulates, it blunts the visibility. So, there is a channel in the speculum. You press the pedal, foot pedal, and smoke will be evacuated. Smoke evacuator is attached with this machine. Another, and it is a low voltage procedure, 50 watt. So, low voltage, blunt current, that is important. See, now if you do not have this machine, we can use any diathermy machine. So that is important to know. And you set the current, cutting plus coagulation, blend current, 70-30 or 80-20. So, and we use, it is called loop, electrosurgical. Loop means we use diathermy loops. Various shapes and various diameters are available, and it is a very thin wire, 0.2 millimeter in diameter. It's either tungsten material or it is steel material, and very delicate wire. Different shapes are available. You have to choose the loop according to the size of the transformation zone, and that is the ball cautery. And in ball cautery, that is for hemostasis. So I'll show you the video. This video is from IARC, but I will show you my personal videos also for proper understanding. I thought it is good for you if we explain this is the animation for type 1 excision. You clean the cervix, then apply Lugol's iodine to demarcate the area. Then it is done under local anesthesia, and you infiltrate xylocaine mixed with adrenaline, or if nowadays we can mix it with vasopressin also, and then you inject it at multiple sites, select the loop, and then you take out this everything in one piece. That's very important. And then you coagulate it to achieve the hemostasis, and when it is dry, then you can put Monsil solution for that. And and this is an insulated speculum, has a smoke evacuator pipe at its anterior blade. So first thing is that you centralize the cervix, and if the lateral walls are invaginating, you cover the speculum with the condom and then cut the top blind end. So, and the condom will act as a lateral vaginal wall retractor. So they have put the condom here. And then first thing is you visualize the findings. You wash it with normal saline, then put acetic acid, timer is on. Always wait for 1 minute. 3 to 5% acetic acid is applied. After 1 minute, you'll see how the lesion has beautifully demarcated. So it is a minor grade lesion, but for demonstration, this has been kept. Otherwise, we can fulgurate the lesion after biopsy, if it is CIN, up to CIN2. Now, for it's better to apply Lugol's iodine. That gives a better demarcation. So they'll apply Lugol's iodine. So you see how beautifully tongue-shaped lesion is prominently seen. And then you have to select the loop. Always follow the electrosurgical procedures. Take the consent from the patient, written consent, and have that the electrocautery plate to so that the patient doesn't get the earthing plate. So properly placed at the hips, which is near to the pelvis. So that should be done. And no point you can be casual. It is an electrosurgical procedure. Then dental syringe is better because that is tough syringe, and cervix is quite hard in consistency. So you take the dental syringe and inject xylocaine already mixed with adrenaline and at multiple points. So it is good for hemostasis and patient won't have the pain. Once it is being done, then you choose the diathermy loop for this transformation zone, which is not very big. You can have a medium size loop, and that mostly average I take is a 2 centimeter wide loop, because too big a loop, it will be too big, and then it's unmanageable. So instead of taking a very large loop, you can do multiple passes, but for this 2 centimeter loop will suffice. And you must have seen there's one shoulder in the I'll show you the shoulder. So the loop is kept on side of the transformation zone. You have to be outside the TZ when you start, and you gently keep the wire on the cervix and press the current. This is the shoulder. So when you press the current, let the loop go till the shoulder, and current precedes the loop. So see, now smoothly it goes, don't stop in between, and you have tailored it to the size of the site of the lesion. So beautifully it is done. There's hardly any, it's like a scooping the ice cream when you do. So a good scoop has come out, and there's slight bleeding that will be taken care of by the cautery. And once the hemostasis is attained, now this was a small loop, did not bleed much, and then you apply, after this we apply Monsul solution, which is semi-solid solution. It has ferric chloride, it is available, and but sometimes you can get it made from your pharmacy. The whole composition is given in the colposcopy IARC atlas. IARC is International Association of Research, and you can open the website, everything is available, and beautiful videos are also available. This is one of the older one when we had distributed to all members of NARCHI. So they say, and when you take out the speculum, these lips will close with each other. You won't see a cavity. It's like a fish mouth. The cervix will close. So that is done. And this is the Monsul solution being applied. It should be applied on a dry surface. Bleeding surface, it will not act. So now coming to the next case where you see this such a big lesion. So first pass has to be through the center so that the whole scamocolumnar junction is intact. Then you can take another pass from the posterior lip, then from the interior. Preferably, first one is the posterior lip, because if the bleeding occurs, it does not occlude the site. So this is was just the animation. Now, if you see the case, this is a huge cervix, big transformation zone. If with one loop, it cannot be taken. So they are applying acetic acid. The percentage of acetic acid to be applied is 3 to 5% for cervix. And you remember 5 E's for loop. One is it's easy to do, easy to learn, easy, it's economical. Why it is so famous? Because it is cheap. Everybody has a diathermy machine. So it has taken a wide acceptance all over the world. Second thing, it is efficacious. Efficacy of the procedure is very important. So the 1E I'm forgetting, I'll remember while I'm taking you through the videos. So now they have marked the area with iodine. Now the loop giving the local infiltration, that is very important. If you are doing a workshop and patient is very hesitant, can be done under caudal or regional anesthesia, but local is good enough, because and that has to be very well given, and it should be long lasting, so mixed with adrenaline or vasopressin. Now when you so have done this, I can fast forward it. Yeah. So before putting the current on, you should do the dummy application. Dummy application means keep the loop on the side and see whether it can go smoothly or not. And then you keep it and press on the current. So you are inadvertently, you can touch the vagina. That should be very careful. It's an electrosurgical procedure. Burns should not be caused on the surrounding structures. So how smoothly, if you stop it in between, there will be thermal damage. Don't stop it in between. So in one go, take out the central tissue, and scamocolumnar junction has been taken out in full entirety. And then you can take the further pieces depending upon the type of the lesion. Whole TZ has to be removed. So it is being taken out. So this is second piece. You always label it. Put it on the cork and then pin it and label that this is a central piece, this is the anterior piece, this is posterior piece. You can go from left to right, right to left, from below upwards, from upwards below, depending upon your space availability and your convenience. So, and never put, when you cauterize, don't touch it. Just keep it near the tissue. It's a spray mode. for fulguration. So automatically the tissue will burn. So once you are done, and don't mop it too hard, otherwise the Escher has formed that will be taken out. After doing fulguration, I prefer to wash it with saline because tissues become very hot. So I put plain saline to wash it off. And then if Monsel is available, not freely available it is, then we keep Monsels. If you have done good coagulation, you can do without Monsels also. So that attaining, now if it is a big chronic cervicitis, big cervix, patients do bleed. So always attain hemostasis. Those 1 to 2% will have major bleed. So in once in my initial years as lecturer, it was a huge cervix and she was type 3, CIN 3, and I did type 2 excision with multiple passes. And at that time there was no bleeding, but then post-op she had good amount of bleeding. I had to take her to OT again and then gave the running stitches. So sometimes they do bleed and you have to observe the patients, but try to achieve hemostasis on the table itself. And so in the next case where top hat excision will be done, and some amount of this is in the endocervix, the upper margin. So evaluation of the cervix is very important. And we don't give antibiotics to the patients, prophylactic. But if the cervix is huge, you think there's an element of chronic cervicitis, it's better to give doxymetro cover. And so once you have painted it, now the apply Lugol's iodine. There's a very wide lesion, you see this lesion, and maybe at this side upper it's going into the endocervix. And to remove this, so first pass will be through the center. That whole of the transformation zone will be taken and the squamocolumnar junction will be one. Then you will make the pass through the posterior lip, then the anterior lip, then we'll do the top hat. With the square loop, the hat will be removed. So this is the lesion. Now the local is being given. Give good local. Sometimes I prefer doing it with regional if it is huge cervix, but this has been done very boldly. Yeah, you see the first pass, now they have taken it out. So the first piece will be taken out. Yeah. So you keep it aside on the table, then take it one more piece because it's a huge transformation zone. This is the second piece. And this is going to bleed. So a good amount of hemostasis should be done. And it's a very easy procedure. You can try on the Lifebuoy soap outside the on the in vitro, and you can also try on piece of chicken or boiled potato. So these loops are disposable. So when they are used, use the used loop and keep trying. Practice you will be makes you perfect. So now again the ball cautery is being applied, and in between she was bleeding too much. That's how they have attained the hemostasis, and now the last portion will be from the top of it. So I want to show you that loop. You see, no, this is still the ball cautery. It's not essential that you should be having insulated speculum. If you use the plain speculum, that is also good. Don't touch it with electro. See this square loop? It is smaller in size and it is square in shape. It takes the depth of the tissue from endocervix. So that you can, and that you should label it separately and send for histopathology. Your histopathology, coordination with histopathologists is very important because we have to ask them whether margin is free or not. So this has been taken. Some people, if it is, you think it was not going so much into endocervix, otherwise at end of the procedure, you can take endocervical curettage. So this is almost end of it. We'll switch on to now other videos. Yeah, so here, this is type 1 excision. This is, we were demonstrating in the workshop, and there was lesion. You can see even the abnormal vasculature. So you do the dummy application of the loop. The 2 centimeter wide loop was taken. It is kept just outside the TZ. Okay. Then when you are taking it, in one scoop you take it. Smoke evacuator is very important. See how beautifully this piece has come out. Now there is no need for any other piece. You take it. Sorry. And next, you see the piece. I'll show you. Yeah, this is the piece. And then we have to measure the leap. At 12 o'clock, you put a stitch so that pathologist gets the orientation, which is anterior, which is posterior. And we have to measure after that, I was demonstrating how to measure it. This is the thickness from what I'll show you in the diagram, how 3 dimensions we measure, that is thickness, circumference, and length of the teeth and this leap specimen. It has been given in IFCPC terminology. You can read from that the how to dimensions of leap specimen. So with the coagulation cautery, now the hemostasis will be achieved. So that will complete our video. Very simple procedure. So nothing, anything high technology to be learned. Yeah, so this is now we also did needle excision or transformation zone. Otherwise, needle is more useful when you're taking a cone with the thermal energy. It causes less thermal damage. So just to demonstrate, we made this video, and you should not be holding this transformation zone with Ellis or tenaculum. You should hold beyond the TZ. Otherwise, it will destroy the architectures of the cell. So local, we are infiltrating with the xylocaine mixed with adrenaline. You inject it all over, and then needle has to be very fine. But our vendors give us the thick needle. So I'm not very happy with the needle we use, and it has to be thinner than that. So don't, this is the needle electrode. See, it is not so thin. It has to be very thin, but still it is refined, thinner than the. So first thing you do is you mark the area all around the TZ with needle. So it is under your control. Leap, sometimes what happens when you put the loop and it goes like this, you don't even realize it has been done. And with needle, everything is under your control. And cone, when you have to do better is do with needle. But here we are doing just excision or transmission zone, seeing that almost the 1 centimeter depth is there, and that specimen will be taken out. And then with ball cautery, you can fulgurate the base. So nothing great, but here it is, we are using needle instead of loop. This is the leap specimen, and when it goes to the surgeon, it should be opened up. It was a ring, so to measure what is the circumference, this whole thing will be circumference from A to B, and thickness will be from C to D, that is from ectocervix to the stroma. That is the thickness of the leap specimen, and the length will be from the endocervical margin to the ectocervical margin. This is ectocervical margin, and F is the endocervical margin. So this will be the length of leap specimen. Similarly, we do it with cone, the same dimensions. So now you have done the leap procedure. It is a daycare procedure. How long you will keep the patient in OT? 2 hours is good enough. It should be done in OT. Written consent is important, and preferably they say you should do it under colposcopic guidance, because it becomes difficult. Colposcope sometimes obstructs the view. Initially you can do without colposcope, then get into the habit of doing it through colposcope. So a patient, after 2 hours, once the patient passes urine, then you see she's not bleeding, you can send the patient home with the instruction that she can have watery or the blood stain discharge for about 4 weeks. And Then avoid sexual intercourse, tampons and vaginal douche for 4 weeks. And she comes after 4 weeks, you'll do a PS examination. Don't do anything else. It will be ugly looking cervix because charring is there. It is still healing. By the time you review the histopath report, and the warning signs will come early if she gets purulent discharge, fever, pain abdomen and heavy bleeding. But if the discharge is persisting even after 4 weeks. So complications, every procedure has the complication. Intraoperative and postoperative bleeding can occur. Intraoperative, I told you how to manage, and severe bleeding also can occur. So you have to manage as and when the situation arises. Infection, the risk is very low. And prophylactic antibiotic, I told you, we're not giving. If there's a discharge is not healthy post-operative, then a patient has fever, give course of antibiotic. Cervical stenosis can occur in these patients if it is a deep thickness. Then, and you have gone into the endocervical canal, top hat we have done, and the incompetence is very rare after GLEEP. So what are the reproductive implications? That it can lead to preterm labor and but the studies have shown that LEAP per se does not cause preterm labor. They say the existence of CIN itself, rather it is that reason for preterm labor rather than the LEAP. So the evidence is not enough that it leads to preterm labor. Conization, it does lead to reproductive complications. So contraindication of doing LEAP are pregnancy. If there's a need in pregnancy, we take colposcopically directed biopsy if required. And if there's no risk of invasion, don't do anything. Colposcopy does not suggest. But if you think there is a risk of invasion, then if one has to take a bigger biopsy, then it should be with LEAP, diathermy, because there's a lot of bleeding in pregnancy. So severe infection, PID, postpone the procedure. Postpartum, delay the procedure until 6 weeks. If the lesion involves or extends into the endocervical canal more than 1 centimeter in depth, then do the cone. And for LEAP, we have, the LEAP cones. These are the electrodes, and it is in triangular shape. Keep it inside the canal and then pass on the current and rotate it by 360 degree. I have not used it. I prefer using needle for the LEAP cone, and mostly the cones are diagnostic, and then we prefer doing cold knife cone. So advantages of excisional procedures, I tell you, tissue is available for histopathology. Invasion can be ruled out with confidence. 0.1% of LEAP specimens done for CIN3 will have occult malignancy. So that is the advantage of doing excisional method, that if there is occult malignancy, that can be picked up. Completeness of excision we can know by knowing the margin status, and it can be diagnostic as well as therapeutic. So follow-up is very important, and good coordination with the pathologist. Now, what will you do if margins are positive? Margins are positive, then that will be my question from PGs. Can I ask them later? They will interact with me. Anyway, if margins are positive,
you can do, ma'am, you can do, madam, if the PGs can.
Okay. So I told you practice to learn the procedure, and we thank our Walter James Penderville professor who discovered this technique. So all over world it has been accepted, very simple method of treating CIN, and effective, cheap, economical, efficacious. Thank you very much.
Thank you so much, Amita ma'am, for your excellent demonstration. And I am sure it will give lots of benefit to the students as well as all to their in their future also. And we are grateful to you for your excellent presentation.
Thank you.
Thank you so much, ma'am.
Are there any questions? No.
Ma'am, we'll check in the chat box if there is anything.
Then I can leave, yeah.
Yeah.
Yeah, Hafizur, can I share my screen? I just wanted to check whether Kahoot is
Thank you so much, Amita ma'am. If there anything will you, and would like to request Dr. Archana to take over for the quiz. Dr. Archana, there will be many students newly joining, so you can just please take them
I
through
will
the
just share
guidelines.
and I will just start then. I just wanted to check.
Sure, perfect. Please go ahead.
I think I have shared my screen.
Yeah, it's.
Is it visible? The game pin is visible, right?
Yeah, it's visible.
So I'll start. Good afternoon, everyone. I'm Professor Archana Kumari, who is Committee Chairperson for year 2025-27. Let me start by expressing my gratitude to FOGSI Office Bearer Sunita Tendulkar Madam, FOGSI President, and Suvarna Khalitkar Madam, FOGSI Secretary General, and of course ICOG Chairperson Dr. Parag Binewala. It was his idea to incorporate this PG quiz in PG clinic. So I'm really thankful to sir, and of course Secretary General Sarita Bhalirao Madam and Hafizur for being a wonderful coordinator always. Dr. Shokumar, Dr. Ashish Makupadhyay, all of you do wonderful job every second Sunday of the month. So I think I'll wait for the student to join. I can see 2 of the participants have joined. This is the game pin. All the PGs can log in into www.kahoot.it and enter the game pin to come into the game, or you can scan the QR code. So we'll be waiting for another maybe 3 to 4 minutes for participants to enter into the game. And today's topic is RH isoimmunized pregnancy. And there will be 25 questions which will be conducted in 3 rounds. I think today Rajesh is busy, so myself and Dr. Bhavna Tiwari from IGMS Patna. She is Associate Professor and she is also the East Zone Coordinator of Quiz Committee. So together with her, I will be conducting today's quiz. So I can see total participants till now is 16. So we have now 26 participants. I think I'll wait for 2 more minutes. I will start at 2:05. Yeah, Rajesh, I just wanted some help for sharing my screen. I have shared, no problem. It was just not right now, but I'm not able. I'm not able to reduce my screen actually. I can see my side view. Okay, I'll adjust from the view. No problem. Okay. So we will, I think we'll start. So the first round will be conducted by Dr. Bhavna. So Dr. Bhavna, here we are going to start the quiz.
Yes,
First
ma'am.
round of 10 questions.
So all the participants just gear up.
So this is round 1. So this is the first question.
RH negative Gravida 2 abortion 1 with RH positive husband has come to you for ANC. She was not given immunoglobulin following the previous abortion. So what will be your next step? Option 1, immediately give anti-D or ICT, go for chorionic villus sampling or test if husband is homozygous for RH factor. So the correct answer is you have to go for ICT. The scoreboard shows that NK was the fastest one and has given the highest score. So great. We are going to the next question. The next question is Gravida 2 Para 1 at 37 weeks of pregnancy with history of previous vaginal delivery with RH negative baby has come for ANC with breech. So what is your management? Go for external cephalic version, expectant management, external cephalic version with anti-D 300 microgram or elective cesarean. Come on. So we have already received 15 answers. Yes, the correct answer is external cephalic version with anti-D immunoglobulin 300 microgram. Let's see. Okay, so the scoreboard has shown a slight change. Sneh has got the highest marks in this score. So fastest one. Next question. RS negative primee has come for ANC at 28 weeks. Her ICT is negative. So what will be the next step of management? Your options are continue ANC and give anti-D, immunoglobulin 300 microgram, growth scan and fetal MCA PSV, deliver at 41 weeks or all of the above? Only one answer till now. The correct answer is you have to continue antenatal care and give anti-D immunoglobulin. I'm afraid no one has answered this. Only one person attempted and that is wrong. So we'll move to the next question. Oh, Sneh is leading the scoreboard. Anyways, we have many questions. Which of the following tests would be most reliable indicator of fetal anemia in an RH sensitized pregnancy? Amniocentesis for genetic testing, Doppler ultrasound for MCA PSV, non-invasive prenatal testing for RH typing, or Coombs test on maternal blood? Already received 15 answers. Great. 16. Come on, 6 seconds left. 5, 4, 3, 2, 1, and it's over. So the correct answer is Doppler ultrasound of the fetal MCA, middle cerebral artery. Coming to the next question. If MCA PSV is more than 1.5 mom at 30 weeks in allo-immunized pregnancy, how will you manage? Go for IUT, expectant management, cordocentesis, or go for cesarean? Oh, faster. 8, 7, 6, 5. I can see 16 answers already coming in. 3, 2, 1, and time is over. So the correct answer is we'll go for cordocentesis. And 5 of you have given correct answer. Can we have the scoreboard? So again, Sneh is leading the scoreboard. Anyhow, we have many questions left. It can be just upside down also. Come on. RS negative G2 aluminize pregnancy at 35 weeks came with MCA PSV of less than 1.5 moms. When will you deliver her? Immediately? 40 weeks? 36 weeks? Or go on monitoring weekly MCA PSV if it is less than 1.5 mom, deliver at 38 weeks. Other students gear up. Only 14 answers till now. This is an easy one. Correct. The answer is weekly MCA PSV. You need to monitor it till it is less than 1.5 mom and deliver at 38 weeks. So 6 of you have correctly answered this question. Great. Very well going. Sneh, I can see she's leading the scoreboard throughout. Others are closely following her up. So next, Gravida 3 Para 2 18 weeks pregnancy. History of RH aluminization has anti-D titer of 1:32 at 28 weeks. MCA PSV is more than 1.5 mol. So what is the appropriate next step? Repeat MCA PSV after 1 month, administer IUT, deliver immediately or start high dose steroids. Three, two, one, done. So the answer is administer intrauterine transfusion. Why? Because the MCA PSV is already more than 1.5 mom. So can we have the scoreboards? Great, great. The same students. Now coming to the 9th question, Gravida 2 Para 1 RH negative women with RH positive partner are concerned about anti-D immunoglobulin. Test to determine fetus RH status. So what will you advise? Clear Bedke test, cell-free fetal DNA testing, direct Coombs or amniocentesis? Fetal RH status. Four, three, two, 1, 12 answers received. Yes, most of you got it right. It's cell-free fetal DNA test for determining fetal RH status. Great. Very well done. So last question for the first round for today's quiz. 32-year RH negative with DCDA twin pregnancy came for routine care at 28 weeks. What is the correct RH immunoglobulin prophylaxis strategy? 300 microgram at 28 weeks, 600 at 28 weeks due to twin gestation, 300 at 28 weeks plus another dose at 34 weeks, or no immunoglobulin needed at all? I can see 7, 8. 8 of you have answered. Come on. Try. So time is up. Yes, the correct answer is 300 microgram immunoglobulin at 28 weeks. It doesn't matter. It is twin gestation. Few of you have mentioned 600 microgram because of twin gestation. No, it's not correct. You have to administer only 300 at 28 weeks. So can we have the scoreboard at the end of first round?
Yeah, thank you, Bhavna, for brilliantly conducting first round. So at the end of first round, we can see Sneh is always leading the scoreboard,
Yes,
followed by SB. I would request the participants to disclose their full name or at least the place where they belong. Anyway, we will continue with the quiz right now. So going to the second round, the first round was mainly based on cases. Now the second round is basically the factual, fact-based round. So here we go to this round 2. And here's the first question for round 2, RH negative, O negative women with husband A positive. What factor may reduce her RH sensitization? Is it ABO group incompatibility or prior miscarriage without anti-D administration, high maternal anti-A, anti-B antibodies, or fetal ABO RH group inheritance? So only 9 could answer, and out of them, 6 got right. It was very easy. Simultaneous ABO group incompatibility always protects against RH isoimmunization. So that is a fact, and 6 of you got it right. Sneh is maintaining the lead, followed by SB and Aarti. Next question. Non-invasive fetal genotype testing is available for which antigens? You read the choices yourself because it is a little confusing. I'll wait for the answers. Come on, I can see only 8 answers. There's no negative marking. You can always attempt. So 7 of you got it right. The right answer is capital C, capital D, small c, capital E, small e, and K. So let us see the scoreboard. It is almost the same as previous one. So next question, true regarding potency of various research antigens are. So read the question yourself. Don't confuse with small a, B, C, D. Actually, that is the option number. So only 5 of you got it right. The most potent antigen is D antigen. So scoreboard is remaining the same, although Aarti has taken lead on the second number. So question number 15 of 25 question, which of the following is correctly matched with respect to the doses of anti-D? First trimester ectopic 150 microgram, second trimester amniocentesis 300 microgram, second trimester MTP 50 microgram, first trimester abortion 150 microgram. This is pretty easy for PG students because we always tell you about the doses. So the correct answer is second trimester amniocentesis 300 microgram. In first trimester, we give 50 microgram only. So 6 of you got it right. And can we have the scoreboard? It is still Sneha leading, followed by Aarti. Next question. Anti-D vaccine is not given in which of the following situation? I mean, vaccine is anti-D immunoglobulin. Amniocentesis at 16 weeks, manual removal of placenta, intrauterine transfusion at 28 weeks, or MTP at 8 weeks. So the correct answer is intrauterine transfusion at 28 weeks. You don't give anti-D during that procedure. For all other, you need to give anti-D. So the correct answer was given by 3 students only. And the scoreboard, still Sneh is maintaining the lead, followed by Aarti. Next question. Which of the following statement is true regarding Rh negative pregnancy? Medical induced abortion does not increase the chance of Rh immunization. 1.5 to 2% case of ABO incompatible pregnancy has the risk of developing Rh immunization. Incidence of Rh immunization in India is 15 to 20%. Genetic locus of Rh complex is present in the long arm of chromosome 1. So the answer are equally divided among all the participants, although the correct answer is 1.5 to 2% case of ABO incompatible pregnancy has the risk of developing Rh isoimmunization. So here is the scoreboard. Sneha and Aarti consistently maintaining the lead. Question number 18. Which of the following best explains the pathophysiology of hydrops fetalis in context of Rh incompatibility? Excessive fetal RBC destruction. Immune antibodies cause fetal neurological damage resulting in hydrops. The fetus immune system overreacts to Rh negative blood. A genetic mutation in fetal blood cells prevents them from surviving. Come on, guys, this is just a simple physiology because you have been reading right from physiology classes. So, and that is proven by your answers. 6 of you got it right. It is just the excessive fetal RBC destruction which leads to hydrops, anemia, and subsequently hydrops. So the scoreboard remaining the same. Next question. After giving antenatal anti-D prophylaxis, postnatal immunization is not required if delivery occurs within 4 weeks, 24 days, 14 days, 10 days. So the correct answer is 24 days. Most of you have got it right. The scoreboard remaining the same. I'll skip to the next question. What is the least amount of Rh positive blood to cause sensitization in Rh positive mother? 0.01 ml, 0.25 ml, 1 ml, or 0.1 ml? This is a simple fact. So the correct answer is 0.1 ml. Even this much amount of Rh positive blood cell in the mother can cause aluminization. So here is the scoreboard at the end of round 2. Sneh maintaining consistent lead, followed by Aarti, SB, and Shraddha. So next we go to the round 3. After intrauterine transfusion, hematocrits decrease by 1% per day. When will you repeat second IUT? After 10 to 14 days, after 7 days, after 4 weeks, or after 3 weeks? Of course, after 10 to 14 days, that was the correct answer. Most of you have answered it correctly. And let us see again, have a look at the scoreboard. It is remaining the same almost. So now we come to this question. Which of the following is not true regarding Ballantyne syndrome? Fetal hydrops, placentomegaly, maternal hypertension, or maternal anemia? I think only 8 people are answering. I don't know why. So 50% of you have got it right. It is maternal anemia. Ballantyne syndrome is a triad of fetal hydrops, placentomegaly, and maternal hypertension. So here is the scoreboard. Again, it is same, Sneha followed by Aarti, but now Shraddha has come up in the third stage. So now all the best to all of you for the last part of image round. So I'm sorry that I said that at the end of round two finishes after the last previous question. Now we come to the round 3, which is image-based round. So here is the first question, false about the above procedure. So you can see the procedure in the image. It is started if the cord blood hemocrit is less than 30%. Rh negative type O blood with low titer of anti-ANTB is used. Amount of blood transfused, there is a formula for it, 10 ml into gestational age in weeks plus 20. Exchange is carried out with one cycle taking 60 to 90 seconds. I'm sorry, only one of you have got it right. The correct answer is amount of blood transfused is this formula. This is for all of the following are true with respect to image zone except. So the correct answer is ICA should be used as a landmark to correctly identify MCA. Actually, this is the wrong statement. All other are correct. So scoreboard again has the lead by Sneh followed by Aarti. Next image-based question, true among the following. You have to look at the image. Patient RBC is taken. Safe level of maternal antibodies is less than 5 international units per ml. Once critical titer is reached, subsequent titer should be done. Critical titer value is 1:16. So the correct answer, most of you have got it right. Critical value is 1:16. Of course, in this indirect Coombs test, you take the patient serum and not RBC. So this is the scoreboard. We'll skip the scoreboard because it is remaining the same. And we come to the next question. All are true about the test being performed. Test is also known as Rossetti test. Sodium hydroxide is used in this test. 80 fetal RBC in 50 low power field represents fetal maternal hemorrhage, fetal-maternal hemorrhage of 4 ml. Hemoglobin F is more resistant to acid dilution than hemoglobin A. So you had to select the wrong statement. So NOH is used in the test is a wrong statement. All other statements were true. This is a Kilhar-Bitke test, which is also known as Rossetti test. So this is the scoreboard. We have come to the end of this quiz. So let us have, no, this is another question left, sorry. So this is a picture, apparently high drop. So you have to look at the choices and select the wrong statement. So option B was a wrong statement, and only 2 of you got it right. But let's see. We have come to the end of the quiz, and here's the podium. Congratulations, Shraddha. You are at third position. Aarti at second position. And we have Sneh at the top position. So congratulations to all the 3 winners. I hope you enjoyed the quiz, because quiz is always a fun way of learning. Whatever you learned during case discussion and theory must have been reinforced by your quiz.
Thank you so much, Arsana madam. Yeah, anything would like to, ma'am?
No, I will stop sharing my screen now, and we'll come back to the Zoom platform. I think I don't know why only 8 persons were answering. They might have a problem in logging in or what, but we can't just ask the participant, right? Because they're not to the faculty link. But maybe we'll take care of that in next.
Maybe we'll
Because in
we'll
the
have to
beginning I
see.
could see 26 participants had joined.
Yes, ma'am. So maybe we'll have to find out. I'll do that if there is any issue in joining for the students.
Maybe their net is
or
not working, or
because
they were not able to.
yeah. Many of them, or maybe you have to reinforce there is no negative scoring, because one of the question I have seen only 1 participant answered. So what is the reason?
That maybe because of less time, maybe, or they were not able to read the.
Or was it like they were thinking that there may be negative scoring also? They should answer every question.
Okay, that is understood. But I'll
so
it next time.
you can just reinforce in that there is no negative score.
In the midway I mentioned about
in
it.
the midway
no
yes,
this attempt.
Yes. I saw after that the suddenly response increased number of responses. So maybe we'll have to see, is there any issues they are facing to joining or login, no? Because that is the thing I'm concerned, especially most of them are connected with mobile. So if they any
I could
issues,
see 26 participants, but answer was coming mostly from 8, right? Bhavna, you were also observing this.
Yes, ma'am. Actually, if they log in by tablet or laptop, it would be easier to see the entire screen, the options.
If they are logging through mobile, it is difficult.
It's difficult for them.
So maybe next time we will just reinforce this thing. Join from laptop. There is no negative marking. These 2
no
things.
negative marking has to be reinforced.
Yes. I will circulate that also, that they should preferably join with a laptop now, because that would be good. Because otherwise the students are interested. Actually, I have got from many students for the joining and inquiry about the quiz. So I feel also like that something is maybe.
Yeah, I was mainly worried about that. Why there are only 8 people are answering? So I was just just for them. Much of effort we take in preparing the questions and all those. So I really want that participation should be more.
Because I feel some of them may not be able to find out how to actually join and enroll. Maybe that may be the reason, because we are doing just for second time today. So hopefully we'll be doing better for next time.
So Bhavna, I think you took the screenshot of podium.
Yes,
thank you. So congratulations all the participants. You will be receiving prizes from ICOG. And
ICOG, true.
Yeah, so we must be thankful to ICOG team under chairmanship of Dr. Parag Biniwala sir for taking this initiative and encouraging PGs to participate in quiz, and also rewarding them by some kind of appreciation. It matters a lot.
Thank you so much, madam. Mr.
Ramnath, for coordinating so well, and you are consistently doing it for past so many years. So hats off to you.
Thank you so much. Thank you so much. So yes, we will next. Hopefully, we'll see you with another topic. which we'll let know very soon for the next month. And
so
Ramnath, yes, ma'am.
So that, we can start preparing well ahead.
Yeah, you can start preparing, and students are also gradually taking interest so that they can also prepare. So that will be nice.
So if they know about the topic, they will prepare in a better way. Yeah.
Prepare nicely. Especially those who are seeing today or participating today. And I honestly feel maybe we'll have to see and find out the issue. Is there any issue they are facing? That I'll do with the communication with this. Mr. Ramnath, I would like to have the details, those who have student logged in, and the those who have in the top.
Can we ask the students to join in the Zoom? And actually we can see their faces and take a picture.
They are, madam, they are in the other platform.
Ramnath, they are in the participant platform, I know.
Yes. So is causing any issues?
Also,
I don't know.
This is being recorded also, sir?
Yeah, this is recorded. This will be in the ICOG website very soon.
Okay, sir.
Ramnath, you wanted to say something? Ramnath or Khushi is there, I think. Anyone is there?
The technical persons.
Sir,
technical.
I'm Mr.
Yeah. Can you give us the details of the students, those who have been in the field?
Okay, sir. I will share.
And because we will need their contact details and everything. And as well as please email me or the students, those who have logged in last 2 classes.
Can they just write in the chat box their name and this thing?
Yes, I think, madam, the 2 of them was our in the case presenting. Aarti, are you there? Aarti and
no, sir.
Aarti and
Shraddha. Yeah, they are here.
So both of you, Aarti and Shraddha, both of your name is there. Is these 2 area?
Yes, sir.
Yes. Okay.
So you were also
madam,
I think
yes, sir.
they were also presenting.
You were knowing the answers, no? Because you were preparing for the case.
No, madam, that's so they were who was the snake? The third, I think that the top and the snake was the name.
Top
I think will not be able.
Was Sneh. Sneh was the top.
I personally feel if Sneha Srishti, she's from my college. So
the top
that
one,
may
madam.
be a reason because he was knowing the topics, he was also preparing.
That's new. Anyway, we'll have this. We told them, madam, if they comes prepared well. In fact, the presenting students, I also told, if they prepares well and they comes and whatever the result, that is also
so
okay with us.
We will circulate the topic well in advance so that they prepare.
Okay, madam. I'll do that in a few. We will let you know also in a few days.
Thank you.
Thank you so much, ma'am.
So we can circulate at least 1 week before that the next topic is this for PG ICOG clinic.
Yes, madam. We'll do that.
Okay.
1 week or so.
So Dr.
I think
Shraddha, you are from which place?
Ames, Delhi.
Yeah. Ames, Delhi.
You were presenting the case, right? I could not log in because I had some other commitments. Otherwise, it is always interesting to be logged in this PG ICOG clinic.
They're having good presentation, including Deepika madam was there. Dr. Deepika Dekha madam.
Okay. I missed that. Okay.
Thank you so much, madam. So I would like to sincerely thank all the FOGSI president, the ICOG chairperson, and all of his bearers, all of our faculties, the institution, including the faculty, Dr. Harish Joshi sir, he has an excellent presentation with abnormal pelvis. And then we have case presentation by Aarti and Shraddha and their guide, Dr. Aparna Sharma. All the faculties, Dr. Ashish Mukhopadhyay sir, Dr. Deepika Dekha. Then we have Dr. Radhika, Dr. Sarita Bhalera madam from ICOG, and Dr. Ipshita Mahapatra. And I especially like to thank Amita Suneja madam, as madam has taken her time for on her busy schedule also on having demonstration in leave procedure. And thank you so much, Archana madam, Dr. Bhavna. Thank you so much. We would like to see you next time. Thank you so much. Next month.
Thank you, sir. Thank you so much. Thank you, Archana ma'am, for giving the opportunity.
Thank you.
Thank you.
Okay. Thank you. Khushi, you can stop recording. Thank you so much.
Yes, thank you.
Thank you. Bye.
Okay. Bye-bye.
Shall I close the session, sir?
Yeah, please close.
Okay. Thank you so much, everyone. So from here, I'm closing this session. Thank you, everyone.